Sir, Ibrahim sir, we will start, sir. Jairam sir, we will start, sir. Sir will be logging in shortly.
Okay, okay.
Yes, sir. So, good afternoon, everyone. So, I welcome you all to the second day of TN Amscon 2026. So, today's special session is on focus on pulmonology. Now, I welcome all our delegates who have registered and who wants to gain knowledge and also get the accredited credit hours, and also unregistered participants who are come in large numbers to gain knowledge and insight into these topics. Now I welcome all our speakers, our moderators for the day, moderator Dr. G. Tilagavati Madam, our speakers Dr. Ria Lawrence, Dr. N. Abhirami, Dr. S. Jayaraman, who is our course coordinator for sleep medicine course as well, our Dr. A.R. Gayatri Devi Madam, and Dr. R. Sridhar sir. So, at the outset, I thank all our members who have shown huge support to our academic programs all these days. So, today's program will be focused more on pulmonology, and we have a 20 minutes of presentation and 10 minutes of interaction, and also a QA session. So, and a few points about our TN AMSCon. So this program has 5 accredited credit hours. We have to attend on all 5 days, and also we have YouTube live link, which is very easy to see. And also, in case you are not missed to enter your medical council register number, just enter into the chat box at later stage also. So before Jailal sir joining, I just want our course coordinator, Dr. Jayaraman sir, to say few words about our sleep medicine course. So kindly proceed, sir.
Thank you, Dr. Sandil sir, for the wonderful opportunity. I'm Dr. S. Jayaraman. I'm a consultant pulmonologist working in the MGM, Apollo First Med, and Bilrath Hospital. I'm the course coordinator for the Sleep Med IMA, Sleep Medima. This is a 6 months course for all the specialties. Those who are specialists in pulmonology, ENT, psychiatry, neurology, internal medicine, diabetology, and the pediatrics, bariatrics, and dentistry. These are all the 10 departments they can join our short term. There is 6 months fellowship certificate course in sleep medicine under the Indian Medical Association Academy of Medical Specialties. These classes all held on all Sundays, 10 a.m. to 1 p.m. There is alternate online and offline classes. So first Sunday online, Zoom meeting. Second Sunday offline at the MGM Healthcare. So we have a kind of, the sleep masterclass and sleep workshop, case-based panel discussion, all about the sleep medicine and sleep surgery. So this will be a very useful course for the postgraduate, those who are doing above mentioned departments like pulmonology, ENT, psychiatry, neurology, and internal medicine, diabetology, bariatrics, dentistry, etc. So this will be under the IMA AMS course, 6 months course. The fee structure will be.
Sir, Jairam sir, now our Jailal sir has just joined, sir. So just we will finish off his session and.
Yes, sir. Good afternoon, welcome.
So now I request, sir, Jailal sir.
Good afternoon, thank you, thank you.
Yes, welcome, sir. So now I request our Professor Dr. Jailal sir, President, Commonwealth Medical Association, past National President, past State President, to give his felicitations. I welcome you, sir.
Thank you, Dr. Sandil. It's an honor and privilege for me to be with you in this wonderful initiative. I'm extremely thrilled to see that almost 1,000 people are joining this AMS program. It gives me a lot of pleasure and joy to see how effectively and enthusiastically our AMS is growing. I know Dr. Jayaraman and you and most of other people who are there, and Nirmal Frederick, all have contributed a lot and impacted this great initiative. It's not an easy job organizing the 5 days continuous program on a different topic and focusing on that particular topic and delivering the wonderful lectures from the top level heroes or top level experts of that particular field is a Himalayan task. And that shows your perseverance, commitment, and passion towards the academic teaching. The purpose and objective for which AMS we have started and initiated in the IMA headquarters is to, I'm happy to see that it is fulfilling through your vibrant activities. We are living in an era where the science is fastly growing. the dynamicity of the newer invention and newer things are fastly growing. At this speed, at this moment, it is mandatory that we have a onerous responsibility of updating our colleagues and updating our doctors with the know-how of the knowledge and skills to them. One of the basic difference what the AMS can do from the routine college is something more than the cognitive skill, and we are going to give something more on a psychomotor and affective domain. I'm so happy that IMA AMS is not only teaching the cognitive part of our medical education, but also teaching when tall experts or the vibrant people are going to talk on a particular subject, the people can pursue and imbibe the affective domain component of it, the ethical component of it, and the hand-holding concept of this topic. So it is very, very effective and essential for the AMS to grow forward. I'm so happy to see that today the topic on the respiratory medicine is being spread by the very tall experts. I'm always very much enthusiastic to know the various activities of Dr. Jayaraman and team. He is one of the asset to Indian Medical Association. We are having him as an asset because he was able to bring the top-notch clinical skills and knowledge on respiratory medicine to our AMS fold, especially on the sleep medicine. He is an expert, and the way he is talking on that. And also it's our social responsibility as we see that more and more lung cancers we are detecting, more and more we know for sure, and we can do it on an early. It will be of great benefit for that. And it cannot say that one reason, but there are multiple reasons are there, then how the people are going to get the lung cancer. So at that level, it is necessary, irrespective of our specialty, whether even if I am a gynecologist, I must know something about the lung cancer and the respiratory problem, because what is the most vital for the people. So attending this kind of AMS, it's mandatory for all kind of specialists, irrespective of our own specialty, and we will be able to get to know about the most important and salient features of a different specialty, and that is going to be of a great benefit for this. On that ground, I take this opportunity to congratulate my AMS team for your magnificent efforts on bringing the vaccination, the respiratory medicine, the effect on eye ophthalmological initiative, and every bit of knowledge and different areas you are bringing, and culminating with the plastic surgery program at the last day. I salute the efforts of Sendil. I know for sure that he is going to contribute more for us in the Indian Medical Association, not only in our state level, but also the national level. We are expecting a lot from him. I know for sure this challenge position of making 1,000 people coming for a CME is not an easy job, which he is able to achieve. That makes him an opt candidate for taking this beyond the borders and the boundaries of our state to the different parts of things. So my greetings and congratulations to the expert speakers. And it tells a lot about you, because sparing 20 to 30 minutes and preparing for that and coming and trying to explain that to the people is a great service, philanthropic activity and altruistic effort which you are doing. So we salute you and congratulate you both from the Commonwealth Medical Association and IMA. I wish and hope that the delegates of this meeting will be definitely blessed and benefited by these topics which of discussion. So my hearty greetings and congratulations, Sendil. Go ahead, conquer, and make sure you are being able to impart the knowledge, skill, passion, and compassion to the people who are attending this. Wishing you all the best, and wish all the best for the Academy of Medical Specialty. Thank you very much.
Thank you very much, sir, for your encouraging word. This is going to be a great boon for all our teams, our chairman, secretary, and joint secretary. Everyone are very much thankful to you, sir. And we will also just want to have a word regarding Stop Tuberculosis initiative of our Commonwealth program. We can have one collaborative program in future, sir, at your convenience. We'll be very much eager to doing this program, sir. Join some way and help, sir.
Yes, sir. We'll be too pleased to do that, and please go ahead and take an initiative, and I will be always there with you.
Okay, sir. Yes, sir. Thank you so much, sir. Thank you, sir.
All the best. All the best. Go ahead, Jairam.
Yes, sir. Thank you, Jailal sir. Namaste. Thank you.
Yes. Sir, Jairam sir, I request Dr. Jairam sir to introduce the moderator and take over the session.
Yeah. First of all, I thank you all the IMA leaders for the wonderful opportunity. I thank our State President of IMA, Dr. Sridhar sir, and State Honorary Secretary Thirvi Mohan sir, and the Finance Secretary Solomon Jaya sir, and the IMA-AMS Chairman Professor Dr. Nimal Frederick sir, and the Dynamic Secretary of IMA-AMS Dr. Sindil Kumar, and the Finance Secretary, that is Joint Secretary of IMA-AMS Dr. Ibrahim, and all the leaders behind the IMA, national and state, for providing this wonderful opportunity platform to disseminate the knowledge across. So thank you one and all. So I thank you for the wonderful opportunity today. You have given to us entire 3 hours for the pulmonology session. So it's an important thing you are giving. Definitely we'll do a good justice to this 3 hours program. We'll do all good take messages. We have a wonderful faculties today. So may I introduce our moderator. So this is the program agenda today. We have a very good moderator and the star speakers, the 5 topics, 5 speakers. And may I welcome Dr. G. Tilakavati ma'am. Today is the moderator of the pulmonology session of Tamil Nadu, Amscon 2026. Tilakavati ma'am is a senior consultant, head of the department, in the Department of Respiratory, Sleep Medicine and Interventional Pulmonology in Vijaya Group of Hospitals, Chennai. Dr. Tilakavati ma'am is a treasurer and co-founder, Association of Women in Pulmonology. Ma'am is associate editor, book Pulmonary Disorders in Women. Tilakavati ma'am is a member of National Board of Sleep Medicine Fellowship, and ma'am has a various association, start from the IMA, AMS, Indian Chest Society, Indian Association of Bronchology, Chest Council of India, and Southeast Asian Academy of Sleep Medicine, and so many organizations. Madam is one of the pioneer leading in all our conferences. Ma'am has been awarded Inspirer in Pulmonary Medicine 2023 by Indian Chest Society, ICS. Ma'am last year organized the wonderful 7th International Conference on Sleep Disorders, that is CSM 2025, as organizing chairperson. I was lucky enough to work with Madam as an organizing secretary. So with that intro, I hand over the mic to Tilakavati ma'am for moderating this session. Over to Tilakavati ma'am.
Madam, please unmute, madam. Tilakavati, madam, please unmute, madam.
Sorry. Now you're able to hear me?
Yes, madam. Yes, madam. Please.
Yeah. Good afternoon, everybody. Thank you, Dr. Jayaraman, for those wonderful words. Respected dignitaries, distinguished faculty, dear colleagues and friends, and especially all the speakers who are my dear friends. It's my privilege and honor to welcome all of you to the pulmonology session of this Tamil Nadu AMS CON Con 2026, which is organized by the IMA, the Academic Medical Specialties Wing of the Indian Medical Association. So, as all of you are aware, respiratory medicine is one of the fastest evolving specialties in your clinical practice every day. Every year in respiratory medicine brings new organisms. You are well aware of it. First it was COVID, then H1N1, then H1N3. So many things, new pathogens, newer guidelines, novel therapies, precision diagnostics, and changing paradigms. The pace with which the respiratory medicine is changing and bringing new guidelines, it's like every 3 months you have to update, and every year the guidelines keep changing. So I think today's scientific program has been thoughtfully curated to provide a concise, practical, and evidence-based update across the major pillars of pulmonology, from respiratory infection to airway disease to sleep medicine, tuberculosis, and lung cancer. We are actually greatly privileged to have an eminent panel of experts who have generously agreed to share their experience and insights with us. So let us begin our academic journey. So I request all our esteemed speakers to kindly keep to the allotted time so that we have a time for a brief discussion on our experience and insights. So the first topic here. So every advancement in respiratory medicine begins with understanding the infections. Infections are the oldest enemy, yet one that constantly reinvents itself. It gives me immense pleasure to invite our first speaker, Dr. Ria Lawrence, who is a consultant pulmonologist at Apollo Medical Center and is known for her academic enthusiasm and evidence-based clinical approach. She'll be speaking on update on respiratory infections. May I invite Dr. Ria Lawrence to deliver her lecture?
Thank you, ma'am, for your kind introduction. Thank you, Dr. Jayaraman and IMA team for this opportunity. My today's talk will be on update on respiratory infection. As we all know, it's a huge topic. So I will try and present whatever deemed important and whatever new updates in the limited time that has been given to me. So starting with the most common OPD patients and most common OP encounters are this one, the upper respiratory tract infections, right and left, during especially now all throughout the year, we are getting upper respiratory tract infection. Most of the upper respiratory tract infections are viral. Approximately 80 to 90% of them are viral and they resolve with just supportive care. The most common viral causes include rhinovirus, influenza, SARS-CoV, RSV, adenovirus, parainfluenza virus, and the seasonal coronavirus, not the COVID variant, the other variants of coronaviruses. So, how do we treat these patients? Usually, it's just symptomatic relief by paracetamol, analgesics, nasal decongestion, mucolytics, steam inhalation, nasal irrigation, throat gargling. We need to avoid antibiotics routinely, and reassurance to the patient is the most important thing that we have to do here. So, do we not at all give antibiotic in upper respiratory tract infections? Yes, we do give. So, there are a few scenarios where we do give antibiotics in URTI, especially in the gas pharyngitis, that is group A streptococcal pharyngitis. If we are suspecting that, then yes, we need to give antibiotics. How do we pick up this group A pharyngitis? There will be high grade persistent fever. If we examine the oral cavity, there will be tonsillar exudates. There are tender anterior cervical nodes, and typically they don't present with cough. They are only present with fever and sore throat. The guidelines recommend, NICE guidelines recommend us to do a rapid antigen test or a throat culture. But in our routine practice, however, we start with antibiotic. The treatment of choice here would be amoxicillin with clavulanic acid, 650 mg thrice daily for 10 days. 10 days is the duration that has been recommended for the gas pharyngitis as per NICE guidelines. Acute sinusitis. This is another common one that we encounter in the OPD. Again, here the most cases are viral. For any acute rhinosinusitis, we can wait up till 1 week to 10 days for it to resolve. We need to suspect bacterial co-infection or a bacterial superadded infection only if the symptoms persist for more than 10 days of duration, or something called a double worsening. Double worsening means initially the patient will see an improvement, followed by there will be a worsening, or there is a persistent high-grade fever for more than 3 to 4 days, or purulent nasal discharge. Again, here the first line of choice, treatment of choice would be your amoxicillin with clavulanic acid with 650 mg thrice daily for a duration of 5 to 7 days. Acute bronchitis. There is no recognized definition of this acute bronchitis. However, in most of the common GP practice or OP practice, we come across the so-called acute bronchitis prescriptions and acute bronchitis mentioned in the documentation. The antibiotics are not routinely recommended. There is no specific guidelines for this group, and there is no specific definition or terminology as such acute bronchitis. Most of these patients are generally the ones who are having an underlying asthma or a COPD, who are coming in with an acute exacerbation. Again, the most common causes would be only a viral. So again, we need to differentiate that, and we need to start antibiotics only if there is a suspected pneumonia or suspected pertussis, or if the patient is a COPD patient coming in with an acute exacerbation requiring antibiotics, or it's an immunocompromised host with a suspected bacterial infection. Coming to the main part of the talk, community-acquired pneumonia. Community-acquired pneumonia is an acute infection of the lung parenchyma acquired outside hospital within 48 hours of hospitalization associated with symptoms and radiological evidence of a new pulmonary infiltrate. Basically, patient presents with a respiratory symptom like cough, fever, along with malaise, fatigue, sputum, or hemoptysis, pleuritic chest pain. Along with it, if you investigate and do a chest X-ray, we would find a new lung infiltrate as seen in the image, or there can be a lobar pneumonia or multilobar pneumonias. So how do we decide the treatment of a CAP patient? Once you're sitting in the OP, a patient with respiratory symptom comes and we do an X-ray, found out it is a CAP. How do we go about it? We look at CURB 65 score and decide whether we are going to treat the patient as an outpatient or an inpatient management. It helps us decide. Sir, my screen sharing is lost. Let me just share it.
Again, you share your screen, Ria. Yeah, it's coming up. Yes, go to your slide.
Yeah.
Yes.
So CURB 65 comes in handy when we have to make a decision whether we are going to make this patient an IP treatment or an OP treatment. So CURB 65, C for confusion or disorientation, U is urea more than 20, R is respiratory rate more than 30, B is blood pressure, systolic less than 90 or diastolic less than 60, and age more than 65 years. Each one carries 1 point. 1 or 0, you can treat it as outpatient treatment. 2 or more than 2, we consider 2 to 3, we consider inpatient in keeping in mind with the co-mobs, access to medical health care and other things. More than 3, we generally advise for inpatient treatment. So what is severe CAP? So we need to differentiate a CAP from a severe CAP for us to understand the further slides and the treatment options and other things. For us to categorize severe CAP, there are 2 criteria, major and minor criteria. So among these, if they have 1 major or 3 or more minor criteria, they fall into the category of severe community acquired pneumonia. So major criteria includes shock, septic shock with need for vasopressors, or respiratory failure needing mechanical ventilation, either invasive or non-invasive ventilation. So either of these 2 is there, we categorize them as severe pneumonia. Minor criteria include tachypnea with respiratory rate more than 30, PO2 by FiO2 ratio less than 250, multilobar infiltrates with involvement of more than 2 lobes, confusion or disorientation, uremia, leukopenia, that is less than 4,000 cells WBC count, thrombocytopenia, hypothermia, and hypotension requiring fluid resuscitation. If it is needing vasopressor, it directly becomes a major criteria and a severe CAP. So what do we do in a routine CAP and a severe CAP? So blood culture is not necessary in routine community-acquired pneumonia cases. In severe CAP, we are advised to take routine blood cultures before administration of the antibiotics. Procalcitonin may be used in guiding the antibiotic duration and other things in routine CAP, but it is not must in the routine CAP. In severe CAP, we need to do procal, especially it is useful for deciding the treatment response, prognosis, and de-escalation of the antibiotics. Respiratory culture, like sputum culture or bronchoscopy or identifying the organism, is not routinely recommended in a community-acquired pneumonia. Only if it is severe, it has been recommended. Or if there is a previous hospitalization of less than 90 days, suspected MRSA or Pseudomonas, or there is a structural underlying lung disease, we need to look for a respiratory culture. Molecular testing for bacteria is not recommended in routine community-acquired pneumonia patients. It can be done in patients with severe CAP if your institution has it. Among the viral tests, influenza can be done if there is a viral outbreak. In severe pneumonias, irrespective of the outbreak or the seasonal variations, we need to do a influenza test. The routine viral panel molecular testings, your RBP testing or biofire film assay, can be done if your institution has it. It is not a must. Urine testing. Urine Legionella antigen in routine pneumonias need only to be done only if there's an outbreak or if there is a significant travel history. In severe pneumonia, irrespective of the outbreak or the travel history, we need to do the Legionella antigen. Pneumococcal antigen is not recommended to be done in routine community acquired pneumonia. In severe pneumonias, yes, we need to do urine pneumococcal antigen as well. ATS CAP guidelines from 2026, the treatment of community acquired pneumonia is empiric antibiotics. Treatment need not be guided by microbiological evidence. We need not wait for sputum culture. We need not do bronchoscopy, or we need not do any throat swabs or any samples. Community acquired pneumonia, we can straight away start with empiric antibiotics. Duration of treatment has been reduced actually. The minimum is 3 days and 3 to 5 days has been recommended. Wherever possible, we have to keep the duration of the antibiotics minimum, that is 3 days. The most ideal thing would be to keep it below 5 days to reduce the development of resistance and other things. Appropriate dosage should be used for these 3 days. Severe community acquired pneumonia, 5 to 7 days or as warranted, depending upon the clinical improvement of the patient. Non-severe community acquired pneumonia, ATS says there's no role for steroids. In severe community acquired pneumonia, there is role for systemic corticosteroids. Again, this here it is a dose of a septic steroid replacement therapy. However, larger studies have not been done. The level of evidence is relatively low for the steroids in severe CAP. The newer mention in this 2026 ATS guidelines that we are looking at is use of lung ultrasound. So ATS says, guidelines says now we can use lung ultrasound in experienced hands and experienced centers, and instead of radiology, wherever it can be replaced. So viral and bacterial co-infection. So whenever a patient comes with a community acquired pneumonia and we do a viral test and turns out to be positive, there is no routine need of empirical antibiotics. But adults with comorbidities or inpatient management of CAP, again, if they're falling into severe community acquired pneumonia with a positive viral test, for example, patient comes in with a pneumonia, turns out to be influenza positive, but if the patient is severe pneumonia or falling into inpatient with high CURB score or comorbs is there, we need to give along with empiric antibiotics. So how to choose the antibiotics in community acquired pneumonia patients? So basically, CAP for standard regimen and recent hospitalization, the regimen is going to be the same. We need to give a beta-lactam and an atypical coverage. In the beta-lactam, we have amoxicillin, ampicillin, sulbactam with ceftriaxone and cefotaxime. We select the beta-lactam based upon whether we are going to give an OP treatment or an IP treatment. And we give an atypical cover, usually azithromycin or the doxycycline. If there is a suspicion of MRSA, we need to add vancomycin or linezolid. If there is suspicion of Pseudomonas aeruginosa, then we have to add anti-Pseudomonals plus atypical cover. Anti-Pseudomonals include piperazoline, tazobactam, cefepime, ceftazidime, or meropenem or imipenem. And we can add one of the atypicals with azithromycin or doxycycline. When do we suspect Pseudomonas aeruginosa and when do we need to give this? In patients with suspected prior history of colonization with Pseudomonas or suspected underlying structural lung diseases, we need to suspect Pseudomonas aeruginosa. So in severe CAP, only thing that is changing is there is an history of recent hospitalization. You are going to add an MRSA cover as well along to your standard beta-lactam with atypical cover. You will add a suspected MRSA cover as well. So along with it, based upon in severe CAP, we are going to do cultures before starting the antibiotics along with your blood culture and respiratory samples. So 2-3 days down the lane, you're going to alter your management based upon your culture results and other PCR reports. So when do we give MRSA cover? If there is a recent history of hospitalization and IV antibiotics within 90 days, or if there is a history of MRSA colonization or infection at any site within last 1 year, or there is a history of MRSA nasal smear to be positive. Only in these cases, we need to add MRSA cover for our pneumonia patients. What if the patient are allergic to beta-lactam? We need to go for fluoroquinolones. The choice of fluoroquinolone here would be levofloxacin. If the patient is having severe cough, we add, along with levofloxacin, we need to add Astriona plus MRSA cover. So where does HAP and WAP stand? For HAP and WAP, the latest guideline that we could get is only the 2016 ATS or IDSA guidelines. The HCAP term has been removed. Healthcare associated pneumonia and empirical antibiotics has been removed. So HAP is pneumonia occurring 48 hours after hospitalization, not incubating at the time of admission. Ventilator associated pneumonia is occurring 48 hours after endotracheal intubation. So, if you see a new or progressive infiltrate on chest imaging, or a new onset fever, hypothermia, leukocytosis, or leukopenia, purulent respiratory secretion, or worsening oxygenations on patients who are already on oxygen, we should think of HAP or VAP underlying. So how do we go about in these cases? We need to do an microbiological sampling definitely in these cases. It can either be endobronchial aspirate if there is a purulent secretion, or we can do a bronchoalveolar lavage, or we can even do something called the mini bulb. So how do we suspect these? Who are all at risk? IV antibiotics within previous 90 days. If there is septic shock, ARDS before VAP, or more than 5 days of hospitalization, or if the patients are on renal replacement therapy, or there is a history of previous MDR organism, or if there is high local resistance rates. So what are the common organisms that we come across in HAP and VAPA? Pseudomonas, Klebsiella, E. coli, Acinetobacter baumannii, MRSA, MSA, and again, VAP also comes with the same. Usually, all these are MDR multi-drug resistant and XDR Acinetobacter and XDR Pseudomonas. So, and each hospital, we have our own antibiogram and we have our own set of MDR bugs sitting there. So, we need to tailor our treatment based upon our local antibiograms. So antibiotic choice, usually we need to give at least one pseudomonal agent for hospital-acquired infections, which will include your piperacillin, tazobactam, cefepime, ceftazidime, meropenem, or imipenem. Or levofloxacin can be chosen if they are allergic to the cephalosporins. We have to add antibiotic coverage if we need to add, because anyways they're going to be on IV antibiotics. Patient is hospitalized. So, or the unit MRSA prevalence is more than 10 to 20%, or the patient in septic shock. Again, the anti-MRSA choice would be vancomycin or linezolid. If the patient is very sick, or patient is in a septic shock or high mortality risk, or it is known for our institute or the ICU or the local antibiogram, it is known for high local resistance, it is better to go with the dual anti-pseudomonal therapy. So, dual anti-pseudomonal therapy, we need to choose two anti-pseudomonals from the two separate groups in case of septic shock and high-risk groups. De-escalation. This is a very important part where we take, once a patient is sick, we take the culture, we start off antibiotics, we start with high-end antibiotics, maybe double pseudomonal antigens, we give MRSA cover in the hope of covering all the organism and saving the patient. But down the lane, 48 to 72 hours later, once we need to follow up the culture, once the culture's flag, once we know it's gram negatives, we need to de-escalate on the gram positives. We need to isolate the organism, and it is very important that we de-escalate the antibiotics to prevent antibiotic resistance. So we need to narrow the antibiotic spectrum whenever possible. We need to stop unnecessary MRSA or dual anti-pseudomonal coverage whenever possible. Once we find out what the causative organism is, we need to stop the broad spectrum antibiotics, and the recommended duration is only 7 days. Again, we need to see each patient how he responds to the treatment and then make the necessary changes. Diagnosis, we need to do molecular tests, RT-PCR, and for influenza, this is next important thing that we are looking at. One of the common thing that we'll be looking at. Just give me a minute. So, yeah. Influenza diagnosis has to be made by molecular test using RT-PCR. It is a must do during outbreaks in OP or IP, and nasopharyngeal secretion specimens are the preferred samples, not the nasal or the throat swab. So, influenza, of course, we know from once November, December, we see a peak of influenza cases. We see patients presenting with body pain, cough, fever, and it is rampant. And in those times, if our center does not have the molecular test RT-PCR, or if the patient is not in a place where it is not accessible, it does not stop us from giving the antiviral to the patient. Treatment. So, whom do we give antivirals? All patients with documented or even suspected influenza. So, you need not confirm with RT-PCR to start on the antivirals. Irrespective of the vaccination history, even if the patient is vaccinated against the influenza, he needs to get the antiviral and the high risk group. We can consider antivirals in OP patients with less than 2 days of symptom, in household contacts, in immunocompromised contacts, and symptomatic healthcare providers. So, oseltamivir 75 mg tablet twice daily is the preferred tablet that has been that's the preferred treatment. There are other options: inhaled zanamivir and IV peramivir. There is a new kid in the block, baloxavir marboxil, which is a single dose. It reduces the viral shedding rapidly, and it is shown to reduce the symptom burden best. But however, it is approved for use only in uncomplicated influenza in outpatients and as a post-exposure prophylaxis in symptomatic healthcare workers or in the symptomatic household contacts. We have to start the treatment as early as possible. That is what the recent IDSA says us. So it is best effective if we start the treatment within 48 hours of the symptom beginning. But if the patient presents to us after 2 to 3 days, treatment shouldn't be denied. That has also been mentioned in the guidelines. So, role of antibiotics in influenza. Influenza and bacteria are known for co-infections, and viruses pave way for bacterial. But when do we give antibiotics in influenza routinely? We have to look for co-infections. We have to suspect bacterial co-infection in patients who fail to improve in 3 to 5 days. In the routine outpatient management, we need not give antibiotics along with oseltamivir. We need to consider it in severe CAP in inpatients and in immunocompromised host. So next, with touching adult vaccination, infection update wouldn't be complete. So I'm just going to touch a little on adult vaccination. So why that has shown 40 to 50% reduction in the symptomatic influenza and 40 to 65% reduction in the influenza associated hospitalization. It also reduces the mortality in high risk groups. Pneumococcal vaccine, significant reduction in the same infections, including hematological and other deeper tissue infections have also known to be reduced. RSV vaccine reduces 75 to 80% of the RSV associated hospitalization. So what are all the recommendations? Influenza, as we all know, it's a 0.5 ml IM injection tetravalent vaccine. We have to give it once a year. All adults, all healthcare workers, COPD, asthma, ILD patients, and patients with most of all comorbidities, CKD, chronic heart disease, and immunocompromised hosts need to receive influenza vaccine. Pneumococcal vaccine. It's a newer vaccine. Earlier, we used to give PCV 13 followed by PPSV 23. Now we have PCV 20, pneumococcal conjugate vaccine 20. This is a single dose vaccine. You just have to give one dose for patients, for older patients who had already received PCV 13 or PCV 15. PPSV 23, we need to give one follow-up of PCV 20, and then we are done with it, one dose, and they're good to go for the lifetime. The choice of group of people is adult patients above 50 years, and COPD, coronary artery disease, again, diabetes, CLD, CKD, immunocompromised host, they all fall into the recommended group. RSV vaccine is a single dose recommended in adults above 75 years of age and immunocompromised hosts. Tdap is also recommended as one of the adult vaccine, as pertussis incidence is supposedly increasing. And Tdap again is a single adult dose, and we need to give a follow-up booster in another 10 years. That is a Tdap booster. So that's a separate vaccine. Tdap adult vaccine is a separate one. So all adults are recommended to take the Tdap vaccine. So take-home messages would be from today's session will be most URTIs are viral, and we need to avoid antibiotics, and we need to diagnose early. Community acquired pneumonia has to be categorized. Risk stratification has to be done. We need to use the CURB 65 score. Once we figure out it is community acquired pneumonia, we need to choose our antibiotics prudently, and the choice would be a beta-lactam antibiotic plus an atypical cover. MRSA cover whenever needed, as in if there is a previous history of hospitalization less than 90 days with monas colonization. How long do we give antibiotics for community acquired pneumonia? It's 3 days minimum to 5 days. Severe community acquired pneumonia, it's 7 days. You can go up depending upon the clinical improvement and your clinical judgment. Again, de-escalate antibiotics whenever warranted. Once your patient is improving, once your cultures are back, once your reports are back, follow it up, look into it, and de-escalate. Stop your MRSA, stop your anti-pseudomonals, make it single anti-pseudomonal agent whenever possible, and reduce broad-spectrum antibiotic exposure whenever possible. Influenza infection, start oseltamivir as early as possible, less than 48 hours. If the patient presents to you late, do not deny. The best effect is seen in less than 48 hours of symptoms. And influenza infection, co-infection with, keep an eye open for bacterial co-infection. Routine need for empirical antibiotic in influenza infection is not needed, but keep your eyes open. If you sense an bacterial co-infection, again, we can give the antibiotics as warranted. Vaccinate. Vaccination is one of the things that has to, we as a country, we need to improve a lot on the vaccination part of our population. So influenza once a year, pneumococcal, the newer vaccine has made our job easier. So PCV 20 once in a lifetime. And that's it for today. And Tdap single dose. So that's it for today. I am open to taking any questions.
Madam, Tilaka ma'am, just unmute your mic, madam. Tilaka ma'am, unmute yourself. Madam, mic, yes.
Yeah. Thank you, Dr. Ria, for that excellent and practical insights on treating respiratory infections. I think the key message she has given is use antibiotics judiciously, diagnose early, investigate wisely. I think, are there any one or two questions for Dr. Ria? The floor is open for any questions. Anybody wants to, should we look at the chat box or? So are there any questions? You can unmute and ask a question to her if you want. Or else, are there any questions in the chat box, Dr. Ria? Do you see anything?
Flu vaccine can be taken any part of the year or taken before monsoon more effective. So Dr. Satish Kumar has asked it. So basically, every year we get a new flu vaccine, new strain is developed, and by the time we get it here, it is October to November. So that is when we give, it is best to give the flu vaccine. If the patient is coming to you, if you don't know when he is going to come back, give at any time possible, doesn't matter.
Yeah, there's another question from Dr. Sundaramurthy. I think, does respiratory infection trigger respiratory atopy? Any role for short-term steroids? I think you discussed the role of steroids in pneumonia.
Yes.
Does respiratory infection trigger respiratory atopy?
No studies as such that respiratory infections trigger atopy. Atopy is a genetic predisposition that a person is born with. So atopy is a separate thing. An atopic person can develop respiratory infection, and atopic person may have an atopic asthma, and that could have trigger with a respiratory infection, not the other way around.
So respiratory atopy is related to IgE and Th2 cells. Anything which stimulates the Th2 cells, I think you can have atopy. It can be a trigger or a modifier. May not be directly linked to it, as she said. The next question is also from Dr. Sundaramurthy. How commonly you repeat chest X-ray in pneumonias?
Sir, in outpatient, basically in chest X-rays in pneumonia, it takes 4 weeks for complete radiological clearance. I'm not repeating the X-ray to see whether it has cleared. The main aim of me repeating in next 2 to 3 days would be to make sure the patient is responding and the pneumonia is not worsening and the infiltrates are not increasing, and making sure the patient is responding to the treatment. In outpatient, if the patient is responding well, I would repeat only after 3 to 4 weeks. In an inpatient management, I would repeat in another 48 to 72 hours, depending upon the patient's clinical improvement and as warranted.
So I think repeating an X-ray, I think it's not warranted by any guidelines. If the patient has clinical criteria which is improving, his general parameters are improving, his vasopressor support is off, his oxygen requirement is decreased, because we should remember that radiological improvement lags behind clinical improvement. The X-ray will look worse many times, but still patient can improve. You do an X-ray whenever you think that this pneumonia has got into any complication like empyema or lung abscess, patient is worsening. So we should keep in mind that X-ray is not the go-to investigation for seeing the improvement. Clinical criteria is more important than this. With that, I think we'll move on to the next topic. So now from fighting infections, thank you, Dr. Ria.
Thank you, ma'am. Thank you
You
for the
can stop
opportunity.
sharing
Thank you.
your slide. Yeah, thank you so much. Yeah.
Ma'am.
So from fighting infections, now we can move on to chronic airway disease, where every guideline update has a potential to improve millions of lives when you have mastered these guidelines. Our next speaker is Dr. N. Abhirami. She's a consultant interventional pulmonologist from Adyar Cancer Institute. She will update us on the recent guidelines for asthma and COPD. The virtual podium is yours, Dr. Abhirami. Unmute yourself. Abhirami, unmute yourself.
Abhirami, are you there?
Am I audible, ma'am?
Yes,
audible.
yes, ma'am.
Yeah.
No,
So is my screen visible?
Not yet.
No, you're not shared. Yeah.
Now it's coming out. Yeah.
Is it visible, ma'am?
No, ma, not yet.
No, not yet. Again, you share the screen.
Now?
You share your screen. I don't think it's visible.
Ma'am, I'm sharing it.
Now you have shared. Yeah.
Oh, it's coming.
Yeah. So
Yes,
thank you
yes.
for that fine introduction, ma'am. My topic for today is update in COPD and asthma. And in 20 minutes, I'll try my best to cover all the important changes that they've made in the guidelines. So my key target for this discussion is going to be what they have changed, why they have changed, and what you have to remember at the end of the session. So first, I'm going to start with COPD. COPD, as we all know, it's a chronic, preventable, treatable disease with persistent respiratory symptoms and airflow limitation. So it is the highest global burden overall, affecting people almost over 390 billion, and it is the third leading cause for morbidity and mortality worldwide. So with irrespective of etiology, COPD is classified as genetically, and then due to abnormal lung development early in the child or which includes premature birth or even low birth weights, and environmental COPD, which includes cigarette smoking, exposure to biomass and pollution, then COPD due to infection, COPD and asthma, and COPD due to unknown cause. Now, how do we confirm COPD? When you get a patient, you do PFT and you look for FEV1 by FEC, and then you diagnose the FEV1 FEC is less than 0.7, then according to guidelines, you actually don't need to do a bronchodilator reversibility testing. But to know the flow response, you can do a bronchodilator reversibility testing. In that, if you see a reversibility, then you can actually monitor the patient closely, and if you don't see the response, then you can confirm it to be COPD. But in the initial in the initial PFT spirometry testing, if FEV1 by FEC is more than 0.7, then it is not COPD. Kindly do post bronchodilator testing. If volume is responded suspected, then or like example, if there is a low FEV1 or eye symptoms, then treat accordingly. Now, the severity of COPD is categorized as mild, moderate, severe, depending of FEV1 value. If FEV1 is more than 80% is mild, and 50 to 80 is moderate, and 30 to 50 is severe, and less than 30 is very severe. All these are the basics. Now we'll move on to the major updates that they have done. So this is a MMRC classification and CAT scoring, which is very much important in categorizing the patient symptoms to mild, moderate, and severe, which will help us in sorting them into category A, B, and E. So patient with mild symptoms come under A and moderate B, and with uh, patients who are having exacerbation. In the previous guideline, it used to be more than 2 exacerbation, but right now they've changed it to 1 or more exacerbation, or more, it's considered in category E. Okay, so when you actually do a CT screening in a stable COPD patient, when you want to diagnose, have a differential diagnosis, or when you want to do a lung cancer screening, lung volume reduction is planned, then all this time you will be doing a CT screening for a COPD patients. Now, this is the overall management of COPD. When a patient comes to you, just ask him for the symptom, look for the risk factors, and do a basic spirometry and do your initial assessment. After you assess the patient, you categorize it so that it will be helpful for you to start the initial treatment based on the guidelines. So, and then check for the smoking status and look for blood eosinophils so that you will know the role if to add ICS or not. And look for other comorbids and start your initial treatment. The initial treatment should be with smoking cessation, lifestyle modification, initial pharmacotherapy along with vaccination. And always, whenever you are starting a treatment, make sure you feed the inhaler by yourself and recheck if the inhaler technique is right done by the patient. Only then the symptoms are going to get under control. And then during the review, you can taper or escalate the inhalers according to the patient symptom. Now, vaccination. What are the vaccinations that you do routinely give for COPD patients? In the vaccination, they haven't changed much. It is exactly the same what it was last year. It is pneumococcal, COVID, pertussis, Tdap, shingles, and RSV. So now, what are the first line management? Group A, we are going to give single bronchodilator, and for Group B, it is LABA plus LAMA, and
Abhirami, you can share your screen again. You can restart. Yeah. Dr. Abhi.
Dr. Abhirami. I think there's some internet.
Guideline. Dupilumab is already there in the guideline, along with which, if patient is on
Dr. Abhirami, your slides are not visible.
Just 30 seconds, we're not able to see the video and audio. Again, you can restart the.
Is it visible now, ma'am?
No, ma.
Okay.
I'm not getting the share option because it shows my screen is already being shared here.
Then you have to close it and then reopen it, I think. No, ma.
Is it?
Not yet. Yeah.
No. You close the PPT and reopen it. Then only I think it will come. Yeah.
Okay.
Connect again.
Now it's coming up slowly.
No, again it's not visible.
Now this is.
Yeah, just give me a minute, ma'am. I'll reshare
Yeah.
it again.
I request all the delegates kindly post your questions pertaining to the topics COPD, asthma for Abhirami.
Ma'am, is it visible now?
No, ma.
Screen share. Technical issues.
Now it's coming up. Abhirami has started screen sharing. Just a minute, we'll wait. It will come.
Ma'am, can I forward my slides?
Just come out of the entire presentation, re-log in, ma. I think that in that way you'll be able to come back. Just close everything, then re-log in and go to your PPT.
Yeah, okay, I'll do that now.
Close even your virtual this thing. You close everything, then join through the link and then come back.
Dr. Abhirami, I think has rejoined. Yeah, co-host only. Abhirami, are you there? Dr. Abhirami?
Can we move on to the next presentation if she's still not ready?
Abhirami, yeah, Abhirami is here only. Now you can share your screen, Abhirami.
Try once more, Dr. Abhirami.
Unmute yourself, Abhirami. Unmute yourself. Now you're muted, I think. Unmute. Abhirami, unmute yourself. Abhirami, you can unmute yourself. You are muted now.
Unmute.
Yeah. Now it's okay. Your PPT start coming now. Abhirami has started screen sharing. Display has come. Yes, Dr. Abhirami. Okay. Okay. Immediately I'll ask to do it.
Yeah.
Juliet, madam, make Abhirami, Dr. Abhirami as a co-host now. So he's rejoined again. I request again make her as a co-host. Juliet, ma'am.
Sir.
Okay. Right.
Unmute. இப்போ பேசுங்க.
Abhirami co-host display as is coming.
My screen is visible now, ma'am.
No, not yet. Not visible, Abhirami.
Not visible.
You check correct co-host Abhirami display as shown. Is seeing now.
So you send the PPT to Jayaraman or something, we can share it, no? That will be better, I think. So I think she can send the PPT to one of the organizers or Dr. Jayaraman, right, Jayaraman?
Ibrahim, sir?
Yes, sir.
Madam has some technical issues, I believe. Not able to reach.
Okay, sir.
So, yeah, just a minute. Yes, Abhi.
Now it has come, I think, sir.
Yeah. Yes.
Yes. Madam, you can go to slide share, madam. Full slide share. Slide show. Yeah.
Yeah.
You got it. Yeah.
Yes, go ahead.
Abhirami, you can unmute yourself. Now you're muted. Unmute yourself. Juliet, ma'am. Please check. Dr. Abhirami is not able to unmute, I think.
Yes, sir.
Abhirami, you can start unmute yourself. You try. Display, I am seeing you are muted. Abhirami.
Sir, host is muting me because whenever I'm trying to talk, it is automatically getting muted mode. I have to be a co-host.
Juliet, ma'am. make Abhirami as a co-host. Not able to unmute. Madam is telling.
Oh, okay, sir.
Dr. Abhirami, madam, நீங்க technical side you can unmute. Dr. Abhirami is sending message, not able to unmute from my side. Technical team, you can please unmute Dr. Abhirami's
Sir, unmuted, sir. Unmuted, sir.
Unmute. Yeah, okay,
Yeah.
Abhirami, now it's okay.
Yes.
Can share your screen, correct?
Yeah.
Yes. Now screen is visible. Go to the full slideshow. Correct.
So we were discussing about adjustment of the treatment, and now moving on, when to consider initiation of ICS or when to taper ICS. Yeah. So whenever there is a history of hospitalization for exacerbation of COPD, say that more than 2 moderate exacerbation per year, or if eosinophil is more than 300, then you should strongly favor towards starting ICS inhaler. Or if there is moderate exacerbation and eosinophil is 10 to 300, then it is not a strong favor, but still you can consider using ICS. When it's totally against the use of ICS is that whenever the patient is having repeated pneumonia or the eosinophil is less than 100 or with a history of tuberculosis, kindly stop inhaler with ICS combination. It is only going to worsen the patient symptoms and condition. So when do we actually manage the patient? When a patient is currently on LAMA ICS, how do we take it further is what this flow chart is representing. Whenever this patient is having no exacerbation but symptoms are like very low, then you can continue the treatment. But this patient is on LABA ICS with the high symptom load with no improvement, then consider escalating to triple therapy, that is LABA LAMA ICS. Or if the patient is having current exacerbation, kindly look for eosinophils. As I told, if eosinophil is less than 100, instead of LABA LAMA ICS, you can choose LABA LAMA alone when eosinophil is less than 100. But for the same patient, if the eosinophils is more than 100, kindly consider triple drug therapy, that is LABA LAMA ICS inhaler. So this is evidence supporting reduction in mortality in COPD patients. So whenever just inhaler is not going to reduce the exacerbation or stop worsening of the disease, along with pharmacotherapy, always there is a role of non-pharmacological therapy, that is stopping smoking. Pulmonary rehab also plays a major role, along with oxygen therapy whenever required. And if in case patient is having bulla or necessary intervention, let it be surgical or bronchoscopic intervention if required, all this put together will help in reducing the mortality of a COPD patient. Now moving on to the current overview of the surgical and bronchoscopic intervention for people with COPD. Say that the patient is having bulla or emphysema or tracheobronchomalacia, then you can always consider bullectomy or stenting or coil or other bronchoscopic procedures like thermal vapor ablation or volume reduction surgery or even lung transplantation. So these are the interventions that I told that will reduce the frequency of COPD. Whatever we have discussed is what they've given here, along with anti-inflammatory therapy also plays a major role, that is non-steroidal, which includes mepolizumab, which is a new add-on to the this year guideline. Now, again, targeted therapy is what again plays for uncontrolled patients who are on triple drug, but still symptoms are not uncontrolled. Then always you can choose dupilumab, which includes biologics for type 2 inflammations, eosinophilic dependent. So these are the evidence based. Because of the time concern, I'll just forward this. And acute care hospitalization, always and always short-acting bronchodilator along with systemic corticosteroids can be recommended whenever the patient is admitted for acute care. But antibiotics for purulent sputum is questionable. You have to, if there is a severe exacerbation, yes, you have to start antibiotic. For mucoid expectoration, you don't have to start antibiotic as an empirical, but if there is in purulent sputum, yes, antibiotic has to be started along with oxygenation. Use NIV if there is hypercapnic apnea in the patient. There is also a new terminology that is added, that is getonomics. Getonomics is nothing but it's a cumulative interaction between gene, environment, and time, that is all put together in individual's life to understand the disease development. So this is going to only shift the focus to prevention and early intervention by analyzing the trajectory of the disease. So this is the overall summary, whatever we have discussed. So whenever a patient is coming to you with the exacerbation, now it can be calcified with including of CRP, VAS, respiratory, heart rate, and also SpO2. So the new treatment goal is target controlling symptoms plus to reduce the exacerbation. So the new role of biologics in COPD, inclusive of anti-IL-5 pathway therapy, that is mepolizumab, is also added on, and also COPD with multimorbidity, which itself is a separate discussion. So any multimorbid that includes hypertension, ischemic heart disease, or heart failure, depression, obesity, or anything that is coexisting with COPD is going to increase the exacerbation. So overall concept is to reduce the inflammation by reducing by also controlling the associated comorbid condition. And also now that they have added a few lines about AI and teleconsultation, which will actually ease the follow-up of the patient. So pretty much that's all about COPD. Now moving on to GINA. So GINA, the new theme and target is that safer acute asthma management, that is starting early anti-inflammatory liver therapy, is what they are concentrating now in the recent guideline. And also they have updated few pediatric treatment options in 2026 GINA, and they have stronger OCS stewardship is what they have informed in detail about it, which we will go through slowly. So this is a diagnosis of asthma, which they have very simplified chart when compared to GINA 2025. So when they have classified into few steps, whenever a patient is walking to you, always examine, take proper history, examine the patient properly, ask for symptoms properly. Why do we do that? To know if the patient is falling under asthma. Only if in case you feel the history and symptoms are not favoring towards asthma and you do a PFT and PFT is normal, always look for alternative diagnosis to confirm. Rather than doing all the investigations to put your patient under asthma category, always look for other options if the patient doesn't fit into this. So what do you do next? If spirometry is available, kindly do a PFT or even peak expiratory flow, broncho, and look for bronchodilator reversibility for this for sure. In COPD, the guideline says there is no need for BDR, but in asthma, for sure, you have to do BDR. That is, you have to see a reversibility of more than or equal to 12%, and 200 ml, more than 200 ml increase in FEV1 from the baseline is considered as asthma. And when it comes to PF, there should be at least 20% reversibility. If in case the PFT is normal or PF is normal, kindly repeat the test whenever the patient is having symptom to confirm your diagnosis. If again nothing favors towards asthma, don't be hesitant to do biomarkers. So biomarkers is not always reliable, because low biomarkers IG doesn't mean that patient doesn't have asthma. Biomarkers can actually lead you in a wrong way. It can either do a overdiagnosis or underdiagnosis of asthma. So all this is what they've given. Step 1, when a patient comes in, as I told you, you take a thorough history to know under what category he fits in, if he is suspecting asthma or not. If in case you're suspecting asthma, then do a PFT. If not, do whenever the patient is having symptomatic to confirm your diagnosis. Step 3 is again, if the test is lung function testing is negative, do biomarker pheno testing to confirm your diagnosis. And once you make a diagnosis or the diagnosis is uncertain, kindly what you can do here is in step 4, you can again give a trial treatment with ICS containing treatment and look if patient is responding. But how long you can continue this treatment? You can give a trial of 1 to 3 months, and again you have to reassess the patient. When you reassess the patient, you feel a patient is again symptomatic, the symptoms are not under control, and patient doesn't fit under asthma, kindly refer him to a higher center or a specialty OPD for further evaluation, or look for other diagnosis. Not always V's falls under asthma. Again, as I told you, they have categorized multiple, they have updated multiple flow charts for less than age of 5, 6 to 11 for acute asthma, both in primary care and in emergency department, which I will explain in detail later. Now, this is a major change that being a general practitioner or a pulmonologist, the change that everyone has to know is oxygen target that has been changed in the guideline. Most of us, whenever a patient comes with acute exacerbation, we look for the oxygen, and if there is a desaturation of less than 94, what we do, we as upfront we start supplementing oxygen. But in the recent guidelines, they have told upfront oxygenation is not required. The target oxygenation, let it be adult or adolescent. For children above 6 years, the target saturation can be 92 to 95. You have a 6-year-old kid with acute exacerbation of OAD with a saturation of 92. There's no need for you to supplement oxygenation. But if a preschool kid is coming to you, then if a saturation is around 92, you can supplement oxygenation. Why are we not actually overdoing with oxygen? What are the reason behind it? Because it can be harmful by hyperoxia, or there can be ventilation perfusion mismatch, or there can be reduction in oxidative stress. So that is why they are insisting us to avoid unnecessary oxygen exposure. So this is one change that we have to do in our hospital, in emergency department, in revising the oxygen protocol. So what we have learned in this slide is that excess oxygen is not going to benefit most of the asthma attacks. Then, so next two topics again interesting. When a patient comes to you with anaphylaxis plus asthma, what are you going to treat first? And the next thing is, why not SABA? Why are they not? Before in the previous guideline, it was all about SABA. Now, why are they not? Why are they saying not to give SABA in a ultra high dose or very often? So all these explanations we will see now. So whenever a patient comes with a anaphylaxis or asthma, always treat anaphylaxis and then asthma. How are you going to treat anaphylaxis? By giving epinephrine, either by IM or nasal spray for a pediatric age group. So after you treat anaphylaxis, then you move on with the bronchodilator, treat asthma. By treating anaphylaxis, inflammation is going to reduce automatically. With the bronchodilator, patient is going to improve. So stop upfront giving nebulization and neglecting anaphylaxis is not recommended in GINA 2026. So we are moving, why not SABA? So whenever a patient comes to us with acute exacerbation, all we do is treat the patient with the repeated nebulization with salbutamol. What happens? With repeated salbutamol, we are only stimulating beta 2. So what happens? Because of this, glycolysis happen and lactate start accumulating. So because of that, there is metabolic acidosis, and because of that, patients start to hyperventilate, acute exacerbation of asthma, and then keep on giving salbutamol, which is not going to be helpful at all. Now, how to know if hyperventilation is because of asthma or because of salbutamol overdose? So say that a patient comes, you are giving salbutamol and you auscultate the patient, and patient is hyperventilating, and now we are going to auscultate the patient. And once the wheeze is subsided, then you can know that asthma is under control and the patient is hyperventilating because of salbutamol. Kindly stop salbutamol. And it is not only hyperventilation. There is also because of excessive SABA, we have good evidence that it also leads to apart from lactic acidosis, tachycardia, hyperkalemia, tremors. All these are the other complications because of overuse of salbutamol. So never mistaken a lactic hyperventilation.
Dr. Abhirami, you're there? Dr. Abhirami?
Madam is
Again,
still there,
lost
madam,
us.
but some signal signal issues is there, I think.
Oh, okay, okay.
constantly saying now that upfront AIR therapy and not SABA. So when are we going to actually use ICS formoterol?
The slides are not
in acute
visible, ma'am.
exacerbation?
Again, same.
Again, ma'am.
Your slides are not visible, but you are audible.
Oh, let me check again, ma'am. I'm sorry, I don't know. Ma'am, it says my slides are being shared again. Give me a minute, ma'am.
Same issue, yeah.
Madam, actually, you are out of our network for some time. Maybe you might have talked, but we have not listened to them. You can just go back 2 or 3 slides and then restart.
Is it okay now, ma'am? Is my slide visible?
No, ma'am. If her presentation with the technical team, they can project the slides, right?
Can I mail my slides, ma'am? Someone else will be able to project my slides?
Yeah, you can send it through WhatsApp to Jayaraman or, like we can.
Ibrahim, Dr. Ibrahim, can you...
How
Madam,
many
you
slides
are,
are left, Abhirami?
Madam, you are already in the Amscon Day 2 WhatsApp group. You can just post it there. From there, we can share it, madam.
Yeah, okay, I'll do that, sir.
You try sharing once again, otherwise you post the WhatsApp our group.
So in the meantime, Dr. Jayaraman, can we discuss the chat group questions till she gets back?
Yes, ma'am. Yes, ma'am.
I think we'll not waste some more time. I think from this presentation, there is one question from Dr. Sundaramurthy. Does asthma overlap with COPD? Any treatment modifications? So asthma, COPD overlap syndrome, the name is no more recognized by GINA or GOLD. So if you, so the main thing about if you see a asthma trait in a COPD patient or a COPD trait in an asthma patient, how you should approach, that should be the idea, right? So if you have persistent airflow obstruction, less than 70% and you don't have reversibility, you have some allergic symptoms or a smoker having asthma trait, these are the groups we are worried about, right? That's what we are talking about. So any treatment modifications, very, very important thing is if you have an asthmatic component in a COPD patient, you should not skip ICS. ICS is not optional, it is essential there. So if in a asthmatic patient, you see a COPD, so it's like this, if asthma, ICS is first, LAMA is second. If it is COPD, LAMA is first and then ICS should be added if there is an asthma component. I think what is the next question? What is the next?
Yeah, I've shared the slides. Can you please display
yes,
my
ma,
slides?
please go ahead.
I'm so sorry for the technical issues. I don't know why is it.
Any other questions in the chat box? Let me check.
Dr. Ibrahim, Dr. Ibrahim,
Yes, sir.
posted the
Yes,
presentation
yes, sir.
on WhatsApp, so you can
Yes,
just
sir, we have-
and start presenting.
Yes, sir, we have received it, sir.
Ibrahim?
Yes, sir, we have received it, sir. I am told to project it now, sir. It will be start in a short time.
Rami, just 1 minute. Yeah, Ibrahim is starting the presentation. You are opening up. Just a couple of minutes. By the time we'll discuss the questions of COPD, madam. Tilaka ma'am?
Yes, shall we
Few
discuss?
questions நம்ம discuss பண்ணலாம்.
Yeah, okay. First question we have discussed. The next
Madam,
question
unmute பண்ணுங்க. Voice கேட்கலையே.
Madam, you are audible. You are audible, madam. Tilavedi madam, you are audible.
Yeah, okay, okay. So we were discussing the questions. So what is the next question? What is the
Yes, madam. Tilaka ma'am?
Yeah, yes.
Yeah,
I'm looking at the questions. Okay. So what is the prognosis in obstructive airway disease between male and female? How is it in asthma and COPD? Outcome of, that's what he's asking. Outcome of asthma and COPD patients, is it different in males and females? Okay, I think asthma, it is females, and COPD predominantly males, most likely. But in COPD, if you have a female COPD patients, I think they will have a symptom perseverance which is higher. They will have some amount of small airway disease component also. But in asthmatics, I think females are the predominant one. Their symptoms, risk, everything scores over males slightly. But I think there are no papers to say that there is definite difference in mortality between male and females or outcomes in male and females. I would like to say that asthma and COPD has moved beyond generalized guidelines. We are talking about precision medicine tailored to particular patient, looking at comorbidities. It is no more generalizing. So I cannot even say what is the outcome for males and females. It is all individualized approach and precision medicine. That's the most important in asthma and COPD. If I have answered it. The next question is, some obstructive airway patients combine allopathy and alternate medicine. Is it a challenge? Abhirami, you can also take by the time your slides come.
It is a great challenge because we are not sure what are the components hidden there. So they end up with lot of poisoning also. And most of this patient, because I'm in intervention, they don't tell us even a minimal procedure will cause massive bleeding, unknown bleeding in these patients. And also their adherence and compliance to the medication won't be as good as regular patients. So because of that, that will be very challenging for us to get the symptoms under control, for the patient to believe in us. That will be the challenging part. But together, I don't see any side worsening because of that. I don't see, but patient come back with a lot of side effects because of add-on arsenic mercury poisoning.
So most likely allopathy, if you combine both medicines, you're going to abuse steroids. So there's going to be an overdose of steroids, which you should be careful about, because most of the time we don't know how much steroids they're giving, what is their content or how much milligram. That's the main issue we should look into. So the next question is, if spirometry is normal, do you recommend higher tests like do you recommend advanced lung function tests like oscillometry or plethysmography, which can catch small airway damage earlier than basic? Absolutely. I think it is the need of the hour. We are moving forward. I think if you are going to establish a spirometry in your clinic, stop, don't buy, go for impulse oscillometry. That will be my message if you ask me today. So there is no use of doing only spirometry. Oscillometry has a great advantage over spirometry in diagnosing early COPD or early small airway disease. And it can, I think slowly in a phased manner, it will replace spirometry. But as far as availability is concerned, I think you have only spirometry as of now. So you can combine spirometry with radiological evidence of small airway disease or early COPD and things like that, and diagnose it early. Anything else, Dr. Abhirami?
Yeah, I stick on to the same. If you're going to invest, kindly invest on impulse oscillometry, because normal spirometry doesn't mean that patient won't be having underlying small airway disease. Is what the conclusion is, what the take-home message. And always don't look for FEV1. Also, always look for LLN Z score in case if you're going to look in PFT. That value is also important.
So always now the latest parameter is FV3 bar FVC6. Okay, FEV3 by FVC6. So and you should look for small airway disease in the later part of your spirometry graph. Just as a clue, but it can't confirm. Spirometry cannot confirm small airway disease or early COPD. So you need some impulse oscillometry or something else. Any other questions are there in the chat box?
Are you able to open the PPT?
My slides are ready.
Ibrahim, sir?
So there are no more questions here. Anybody wants to ask a question, you can unmute yourself and ask. Please feel free to ask.
Sir, Jayaraman sir, there is a problem in the network itself, sir. In the Zoom network itself. We are trying from the Juliet is trying, sir, again.
So how many more slides you have, Dr. Abhirami?
Just the treatment, ma'am, track 1, track 2, and then
Okay.
little about biologics.
Yeah, it's come now. Yeah.
And the pram.
I think your slides are back. If they can bring it to the old one.
Juliet, madam, go to the full slide show. Move the slides. Abhirami, please catch your slides. Which slide you want to present from treatment?
Yeah, come down.
Can you go? Can you go
down,
please? Further down.
Next slide.
Further down. Yeah, you can hold. Can you move one slide? Okay, okay, you can stop here. Next slide,
go ahead,
please.
Dr. Abhirami.
Next slide. Yeah. So this is one scoring that everyone should remember, that is PRAM score, which includes SpO2 and suprasternal retraction, scalene muscle contraction, air entry wheezing. All this put together will be able to categorize pediatric group if they're, depending on the scoring, if it's mild, moderate, severe. With this, we'll be able to escalate the inhaler therapy. So the scoring mild is 0 to 3 and moderate is 4 to 7. And you can take a screenshot of the score and it's available in GINA guideline. Move on to the next slide. And this scoring is applied only for up to 17 years of age. And this is bronchodilator responsiveness. So previous in ERS, I suppose in 2022, 10% responsiveness even in FE1 can be considered as asthma. Now in GINA 2026, the value continue to be more than and equal to 12% and more than or equal to 200 ml increase in FE1. Why are they strongly relying on 12% is because true asthmas can become negative if the value is going to be 10. So that we are going to only underdiagnose asthma patients, which we don't want to, especially this is most common in younger male group. So the value is still going to be more than or equal to 12%. Next slide, please. What are the major change in children of 6 to 11 is that, again, daily, previously it was only SABA alone and daily ICS and SABA were the dominant strategies, but now again AIR, that is anti-inflammatory liver therapy, enters the pediatric early step treatment is what you have to know. Next. So this is GINA 2026 track 1. That is track 1 is the preferred control and reliever therapy. So in step 1 and 2, it is as needed low dose ICS formoterol. But in step 3, it is low dose maintenance ICS formoterol along with MART therapy. But in step 4, it is medium dose ICS. In what you have to know is that in step 1, that is upfront itself, we are starting ICS. And in step 5, it is Now, biologics and along with triple drug is also added. But what is this alternative controller reliever therapy? Only when ICS formoterol is not available, you can consider using SABA along with ICS is the alternative control and reliever regimen. But always preferred is ICS formoterol as a initially start with low dose and go till medium dose. Move on to the next slide, please. Next slide. Next slide. No, the previous one. Previous one, please. One slide. Can you scroll down? Okay. One slide down. You're scrolling up. You have to go down.
Forward போடுங்க. Juliet ma'am, go to forward.
Can you scroll down? You're going down. You're going upwards. You're supposed to go down. Next slides.
Yeah. Next.
Next slide. Yeah. Okay. You can stop here. Therapy. Now that before triple therapy used to be in GINA also. The benefit is under control. Always go for biologics. But next. Am I audible?
It's audible, Abhi.
Yes.
Yes. Go ahead, Mark.
Okay. So if for severe eosinophilic asthma management, you can always go for long-acting injectable, that is depemokimab, which can be used 26 weeks once, but the approval is only for age group about 12 years. And then again, you have to, the other option is that omalizumab, and also now that we have a similar one, that is omalizumab IGEC, which includes again for severe asthma pathway, which actually the cost burden, the concept of bringing the similar biosimilar anti-IgE is because to reduce the cost burden. Next one. I'm not going into the mechanism of action, it's just I'm going to tell you the changes that they have done. Next slide. Next slide. These are the other biologics which can be used in other conditions apart from non-asthma conditions. And now the new add-on is the GLP-1 receptor agonist, which is actually improve in asthma outcome in obese patient. However, the treatment recommendation, it is not recommended in the guideline, but we need further research and evaluation. But in future guidelines, we can expect GLP-1 receptor to be as a part for obesity as a comorbid. Next. So stronger focus on OCS is because why are the targeting to reduce the oral steroids is because to minimize the risk associated with excess use of OCS, which include risk of cardiac disease, diabetes, osteoporosis, adrenaline suppression. So that is why we are targeting towards biologics to reduce the use of OCS. Next. Is still remain the same. There is no change in vaccination. It is again flu vaccination, RSV, COVID, pneumococcal pertussis, which will help them in preventing the exacerbation. Next. Okay. So the overview, I want to give just a small summary because there was no continuation in GINA. The key points that I want you to take home is the oxygenation. So during acute exacerbation, when the oxygenation, concentrated on oxygenation, when saturation is less than 92, then you supplement oxygen. oxygenation, or if the patient is in respiratory failure, say that a patient is severely tachypneic, you can supplement oxygenation practically, even though guidelines doesn't say that. I think Tilaga ma'am will also say, agree to it, I suppose.
Yes, ma.
And then reduce the use of use of SABA. Consider there can be lactic acidosis, and because of overuse of SABA, patient can always hyperventilate. So always the target is treat the inflammation, because asthma primary, the underlying is because of inflammation. So treat the inflammation and go for bronchodilator. And whenever and the next point is that always make sure when to escalate and when to taper down the dosage of ICS. Try controlling ICS also when it comes to COPD. These are the take-home messages that I have to say you. And not only inhaler is going to help you. Whenever the patient is going to come back to you saying that symptoms are not under control, kindly make sure if you have prescribed right choice of inhaler, and recheck if the inhaler is taken properly. If patient is following every step of the inhaler, only then you go increase or step up the medicine to double or triple regimen. Thank you.
Thank you, Dr. Abhirami. That was a wonderful summary of GINA and GOLD, a bird's eye view about GINA and GOLD latest guidelines. So as I said, modern asthma and COPD treatment has evolved from one size fits all to a personalized medicine, where you have to take into account phenoendotype, biomarkers, exacerbation risk, and individual patient characteristics, like how you told obesity-induced asthma. So it is actually tailored down to the individual. It is no more just prescribing inhalers across the board for all COPD and asthma. And the message in this forum I would like to say is, there is some inflammation which is driving the bronchospasm. Please get to the root cause of what is driving that inflammation, which is more important than just prescribing inhalers and nebulizers to these patients. So in my practice, I upfront phenotype the patient. So you need to phenoendotype the patient before just blindly stepping up the therapy and then landing up in biologics. I think that's the most sensible way of approaching obstructive airway disease in this present current scenario. So thank you very much, Dr. Abhirami, for that wonderful talk. As there is less of time, we'll move on to the next topic. So let us explore what happens to breathing while you have a disturbed sleep, a condition which silently affects every organ system. It is now my pleasure to invite one of the pioneers of sleep medicine, Dr. S. Jayaraman. Can I have a slide? Introductory slide. I think Dr. Jayaraman needs no introduction in this forum. Everybody are well aware of him. Very, very enthusiastic, energetic, always, into some academic involvement. So it's a pleasure, a dear friend of mine. So he's a senior consultant, I think all of you are aware, from MGM Healthcare, Apollo First Med, and Bilroth Hospital. He will be delivering, he's a Vice President, Association of Pulmonologists of Tamil Nadu. He's a Vice President-elect of IMA TNSB North Zone. He's a Treasurer of CSM. He was a co-organizing chairperson along with me. Maybe his role was the major role in the CSM 2025 Chennai conference. And he's also a president, Rotary Chennai Medical Fraternity 2025 to 26. I think he has many more accolades in his, but there is no place for the slide. I think that's why he has restricted this. So Dr. Jayaraman, please, we look forward to your insights. The platform is yours.
Thank you, Moderator Tilaga ma'am, for the wonderful opening remarks about this program. So first of all, thank you IMA and IMA AMS team for this wonderful opportunity to present my topic in this August gathering for Tamil Nadu Amscon 2026. So thank you. My topic today is the sleep disorder breathing. You all know very well, sleep disorder breathing is an umbrella term, is a spectrum of disease starting from the primary snoring, upper airway resistance syndrome, obstructive sleep apnea, central sleep apnea, chain stroke respiration, overlap syndrome, OSA and COPD, Pickwickian syndrome, nocturnal hyperventilation, complex sleep apnea. There are a lot. So it's an umbrella term mainly in the sleep apnea group, the sleep disorder breathing. the obstructive sleep apnea, OSA, is a very common practice, we see in a clinical practice. So it's the most common type of sleep apnea, OSA, obstructive sleep apnea, caused by the partial or complete collapse of the upper airway, characterized by repetitive pauses in breathing during sleep despite the effort to breathe. Occur for a minimum of 10 seconds, individual may not be aware of the problem. So next is the central sleep apnea, so characterized by lack of drive to breathe. Results in repetitive pauses in breathing with no effort. Occurs for a minimum of 10 seconds. And chain shock respiration, CSR, characterized by cyclical alternating pattern of increased or decreased periods of breathing, typically followed by a central apnea, a form of another disorder that is often associated with the severe heart failure patients, those who have suffered a stroke or who have experienced brain injuries. And finally, nocturnal hyperventilation, a reduced rate and depth of breathing. It occurs due to the loss of muscle tone during the sleep and especially during the REM sleep. Often occurs in patients with a chronic obstructive pulmonary disease, neurological impairments, restrictive disease like scoliosis, or those who are obese. So these are the common sleep disorder breathing. Among all, OSA is very common. Coming to the basics of sleep, the triumvirate of health. There are three pillars of health. One is the sleep, physical activity, nutrition, as per the father of sleep medicine, William Charles Deman. This gentleman is call it as father of sleep medicine, invented REM sleep, polysomnography. He was the first sleep physician, started a sleep clinic in Stanford, USA. So he's a neuropsychiatrist, basically psychiatrist and well versed in neurology. He's a neuropsychiatrist. The American Heart Association recently included sleep is one of the very important among all the 8 factors. So sleep is in paramount importance. Sleep and diet, exercise, and glycemic control, weight maintenance, lipid control, blood pressure control, and avoidance of tobacco smoking. These are the life essentials for the good life, happy life. The prevalence of obstructive sleep apnea among all the sleep disorder breathing, OSA is very common. It has a lot of comorbids. It may lead to a lot of problems like a stroke and atrial fibrillation, heart failure, drug-resistant hypertension, diabetes, obesity. There are two-way process. To start with a brief case presentation. This is a 63 years male. It's known hypertension on 2 tracks. Patient presented to the emergency with a and weakness one half of the body for just duration. In the emergency room, radiological investigation showed there is no abnormal diagnosis. Patient was admitted to Neuro ICU. The diagnosis was TIA. He is one of the forerunner of stroke, CVA. Past history of sleep apnea test done 2 years before, not on any treatment. The time advised to undergo the PAP titration and all. This time we repeat the sleep study on 4th day before discharge. We advised to use the CPAP for severe sleep apnea. Coming up for the checkup regularly. The BP, everything is under control now. So case 2, this patient, 49 years male, presented to the emergency department with recurrent stroke, CVA. Etiology behind is atrial fibrillation due to OSA. And retrospectively, we asked the bed partner, snoring and daytime excessive sleepiness. Patient was obese. We did a sleep study. We showed severe OSA and PAP titration was done and PAP therapy prescribed. This is another patient underwent implantation, pacemaker implantation for the AV block and all. And the patient is having a lot of residual sleepiness plus excessive daytime sleepiness, etc., obesity. And we did a sleep study. We showed very severe obstructive sleep apnea, so which was treated by PAP therapy. What is the link between the obstructive sleep apnea and atrial fibrillation? The mechanism behind OSA, which leads to inflammation, hypoxia, autonomic imbalance, intrathoracic pressure changes, which all leads to heart failure, hypertension, atrial remodeling, which eventually leads to atrial fibrillation. This is the case 3, 6 years male, who presented to the OP department with a frequency of micturition mainly 6 times at night time. Evaluated initially for benign prostate hypertrophy, diabetes mellitus uncontrolled, and UTI, but all ruled out. Finally, this patient referred by urologist to me for sleep apnea evaluation. Patient had a history of snoring, BMI 32 in sleep study in the obesity scale, and sleep study shows severe obstructive sleep apnea, AHI of 38 per hour. CPAP initiated. After 2 months, the nocturnal symptoms reduced to one-time nocturnal awakening because of nocturia. And this is the etiology. This is the mechanism behind OSA and the nocturia. OSA, which leads to increase in intra-abdominal pressure, increase in atrial natriuretic peptide secretion, and increased arousal, which all leads to nocturia. And this is the last case, 55 years female, no diabetic, obesity, present to the acute emergency department, acute abdomen, laparoscopic. This is a cholecystitis, patient underwent lap cholecystectomy. Post-operatively had a respiratory distress in the form of dyspnea, tachypnea, and desaturation. Required NIV and high insulin to control the diabetes mellitus. I was called to see this patient in a recovery room. Patient had a history of obese, history of snoring, excessive daytime sleepiness, witness apneas as per the bed partner. Sleep study done third day in the room, which showed a very severe OSA. CPAP started. Patient discharged in good condition. Patient is on regular follow-up. For obesity management, we are giving with the endocrinologist care. Snoring is a spectrum. First spectrum of sleep disorder breathing or sleep-related breathing disorder. Snoring is an abnormal respiratory sound during sleep because of turbulence of airflow in a narrowed airway. Because of vibrations from the upper airway wall causes the snoring sound. Simple snoring due to cold, allergy, and infections, DNS. The sleep apnea snoring is a habitual snoring. Breathing passage, mainly the retropalatal and retroglossal areas, narrows while sleeping and produce a partial or complete blockage of the upper airway. OSA is another spectrum, very important, very common disease. You can see the pictorial representation, normal upper airway. This is a narrowed, complete blockage of the upper airway. Apnea, hypopnea, behind the tongue, behind the palate. India is a high prevalence of sleep apnea, high sleep apnea burden country. There are a lot of symptomatology, day symptoms, excessive daytime sleepiness, feeling tired, fatigue, early morning headache, mostly in female population, diabetes, concentration, memory problems, high BP, depression, anxiety, irritability, learning difficulties in children. Night symptoms, snoring, increased frequency of urination, nocturnal polyuria, irregular breathing during sleep, partner witnessed stoppage of breathing, night sweats, increased cough, salivation, sexual dysfunction, palpitations. Endone phenotypes are very important. Nowadays, we are all practicing in an era of precision medicine. We will diagnose precisely. For that purposes, we have to have the phenotyping. It's very important. So one size does not fit for all. Each patient is different. We have to have the individualization of each and every disease. The common comorbids are metabolic disease syndrome is that COPD and cardiovascular diseases like hypertension, atrial fibrillation, etc. Based on the anthropometric measurement, age, gender, and body weight, based on symptom. This is very important. There are 3 groups based on symptom. One is the hypersomnia, other one is the insomnia. In between the minimally symptomatic area, asymptomatic group. No snoring, no excessive daytime sleepiness, but patient is having other comorbid conditions, diabetes, hypertension, uncontrolled, etc. We have to evaluate for that whether OSA is there or not. Based on the PSG, polysomnography, there are 2 phenotypes again, REM OSA and positional OSA. And lot of pipeline markers we are going to get very soon. And this is the endotypic classification based on pathophysiology. I'm not going to detail about the phenoendotype and all. This slide shows pathophysiologic mechanisms and consequences of OSA. These 2, apnea, hypopnea, leads to 3 major events: sleep fragmentation, hypoxemia, negative intrathoracic pressure, which leads to sympathetic surge, hemodynamic effect on the cardiovascular system, oxidative stress, inflammation, endothelial dysfunction, hypercoagulability, endocrine dysfunction, which all leads to diabetes. Cardiovascular disease, mainly hypertension, arrhythmias, coronary artery disease, stroke, congestive heart failure, pulmonary hypertension. The sleep fragmentation directly leads to the neurodegenerative diseases like dementia and Alzheimer's, accidents because of sleepiness, road traffic accidents, poor quality of life. Coming to the sleep and diabetes relations. Well-controlled diabetes leads to better sleep, and better sleep leads to better control of blood glucose levels. Refreshing sleep and restorative sleep can improve glucose metabolism, reduce sleepiness during the day. Sleep apnea. The most common sleep disorder in people with diabetes is sleep apnea. In 2019, 2009 study published in Diabetes Care found that 86% of people with the diabetes also experience sleep apnea, with 55% reporting moderate to severe apnea warranting treatment. One reason the numbers are so high is because of the excess weight associated with type 2 diabetes, which can lead to extra fat in the neck that constricts the airway. People with overweight may develop a sleep apnea before they develop type 2 diabetes, and that sleep apnea can contribute to its development. What is the pathogenesis of metabolic abnormalities? Sleep apnea, which leads to hypoxia arousal, which leads to type 2 diabetes. Other mechanistic link, sleep fragmentation. Because of sleep apnea, sleep fragmentation, intermittent hypoxia, sympathetic activation, high-speed dysregulation, systemic inflammation, which leads to insulin resistance and type 2 diabetes. The intermittent hypoxia directly leads to beta cell dysfunction, causes type 2 diabetes. A lot of clinical questionnaires. Well, the common questionnaire we ask the patient attender, patient spouse, husband or wife, we ask the stop bank questionnaire, which is the common thing. This is a very easy questionnaire to assess whether patient has sleep disorder breathing or not. OSA. Yes, snoring. T means tiredness. O means observed choking or not. P means pressure, blood pressure. BANG, bang, stop bang. B means BMI, age, neck, N for neck, G for gender. So you have to ask these questions and put the mark like yes, no. First question, do you snore loudly, louder than talking, or loud enough to be heard through closed doors? Yes or no. Do you often feel tired, fatigued, and sleepy during daytime? Yes or no. Has anyone observed you stop breathing during sleep? Do you have, or are you being treated for high BP? BMI more than 35 kilogram per meter squared, age more than 50, neck circumference more than 16 inches, and gender male. So a score of 2 or less is considered low risk, and a score of 5 or more is high risk for having the either moderate or severe OSA. Another important scale is the excessive daytime sleepiness assessment by F4 sleepiness scale. These are the situations we have to ask chance of dosing sleepiness. So sitting and reading, what is the score? Watching television, sitting inactive in public place, as a passenger in a car, lying down to rest in the afternoon, sitting and talking, sitting quietly after lunch, in a car while stopping in traffic. We have to put the score like 0 means so would never dose, 1 slight chance of dosing, 2 moderate chance of dosing, 3 high chance of dosing. Based on this, if the score is 1, if score is 0 to 6, 2 if the score is 7 to 10, 3 is 11 to 13, 4 if score is more than 14. So high score indicates excessive daytime sleepiness, more in favor of the OSA. How to confirm clinical and questionnaires? Apart from this, what is the confirmatory test? Sleep lab, sleep study. That is polysomnography. Level 1 study is the gold standard test to confirm all kinds of sleep disorders. And we have a home sleep test, mainly the polysomnography. This is the home sleep apnea testing. Type 3 study, we call it as the polygraphy. Type 4 is a screening test. Once you diagnose obstructive sleep apnea, weight loss, we have a lot of bariatric medicine available now. Alcohol cessation, alcohol will worsen. It leads to loss of upper airway muscle tone, mainly the hypoglossus muscle and all. Position therapy in a case of mild to moderate disease. So we have to have the position treatment, tell the patient to lie down in the lateral decubitus to avoid the tongue fall back and upper airway narrowing. Nasal decongestion, one of the adjuvant treatment for any allergic rhinitis. Mild defect in nasal septum, we can use these kind of medications. These are the common clinical conditions we come across in our practice left to right. Whether you are a physician, surgeon, anesthesiologist, physician, pediatrician, so these are the common disease, oncologist, very common disease we have to evaluate. Systemic hypertension, obesity, myocardial infarction, stroke, pulmonary hypertension, type 2 diabetes, nocturnal cardiac arrhythmias, driver involved in a sleep-related automobile crash, preoperative anesthesia evaluation, and controlled asthma, one of the common comorbid conditions, cancer. These are the conditions we have to evaluate. Obstructive sleep apnea, one of the common clinical conditions, comorbid conditions. Polysomnography is a gold standard. We have to measure all the parameters. We have to assess the sleep stages by putting the electrodes in the scalp region. and chest leads and the abdomen leads and chin leads and the all the leads which help in diagnosing we can derive various metric index. The main metric index is AHI. Beyond AHI, we have the RDI, that's a respiratory disturbance index based on arousal index. So polysomnography is a gold standard in-lab test. This is a meticulous monitoring throughout the night, minimum 6 to 8 hours study. So we attach these gadgets from head to foot and tell the patient to lie down. Proper counseling is mandatory for the patient as well as the patient family. For the level 1 study, meticulously we must tell sleep physician and sleep technologist, sleep nurse has to tell such a way that the study is to find out the sleep disorders of various etiologies, whether OSA, narcolepsy. There are a lot of diseases we can diagnose from the type 1, a level 1 study. Level 2, this is a hospital study, not in the sleep lab. Outside the sleep lab, in the bedside, or in the hospital, outside the hospital, in the home we do. This is called as a home sleep apnea testing. The same level of monitoring we do. Only thing is unattended, without technician. So we attach, then nurse will take care of everything. This is a level 2 or polysomnography, home sleep apnea testing. Type 3 study, we call it as the polygraphy. We measure the nasal flow, respiratory effort, oxygen, saturation, pulse, and snoring. This is record mainly the cardiorespiratory aspect, polygraphy. Indications are very clear. No comorbid condition, straight away, high probability in these questionnaires, you can go for this. Any comorbids, we have to go for the level 1 or level 2. Level 1 is always the gold standard sleep study, in-lab study. Nowadays, we have a lot of advancement happening based on the AI, artificial intelligence incorporations. This is a test called this is one sleep test. Simple, accurate, multi-night testing, safe way to start one sleep tracking based on the peripheral artery tonometry and photoplethysmography. In future, this may replace the gold standard level 1 study also. So we have to wait and what we need more data. Once you confirm the diagnosis of OSA, what kind of treatment? Treatment based on the etiology, phenotype, endotype, multidisciplinary team. One size does not fit for all. We have to form the sleep board. Like a tumor board, we have a sleep board, which consists of pulmonology, ENT, endocrinology, psychiatry, bariatrics, dentistry. We have to involve and give the treatment because OSA is a long-standing, lifelong disease, may require treatment lifelong. PAP therapy is a gold standard treatment for obstructive sleep apnea. What is CPAP? Continuous positive airway pressure. First described by Professor C. Sullivan et al. In the Lancet in 1981 as treatment of obstructive sleep apnea. It works as an air splint to maintain upper airway patency during sleep. It's the most effective non-invasive therapy. You can see the opening above the airway. This is Professor Dr. Colin Sullivan, is inventor of CPAP in 1980. PAP therapy, the mechanism behind it keeps airway open. During sleep, we have to wear for 6 hours as per the recommendation. Different types of positive airway pressure therapy, continuous positive airway pressure, auto-adjusted positive airway pressure, bilevel support, BiPAP, both inspiratory and expiratory, the missional support. Indications vary from the normal CPAP. This is the interfaces. Interface, very important. Facial mask. Nowadays, facial masks are very, very patient-friendly. This is the nasal mask, and this is the nasal pillow chin strap. Those who are having open mouth breathing, we have to give the chin strap to prevent air leak through mouth. Nasal insert, nasal pillow, full face mask. Nowadays, we give only the nasal pillow. It's a standard of care for OSA interface. Various kinds of machines are available. Portable machines, simple. Coming to the non-surgical management, oral appliances is considered as a second-line treatment. Those who are not able to tolerate the PAP therapy. So we have alternative treatment, oral appliances. We have to get opinion from the maxillofacial oral surgeon. There is two options. One is the mandibular advancement device. Other one is the tongue retaining device. Adjustable mandibular repositioning devices are available. Surgery plays a third role, major role, but this is not this one. In children, adenotonsillectomy is the preferred treatment, first-line treatment in the pediatric age group. In adult, mild to moderate OSA, in young or middle-aged individual, there are a lot of upper airway surgeries. Maxillomandibular advancement osteotomy for retro and micrognathia. Because we have to do the electrical capillary and find out whether the patient has retro and micrognathia. Bariatric surgery for morbidly obese patients. This is the MRI upper airway. You can see clearly there is a retropalatal and retroglossal normal airway. You can see the collapsed airway in the upper retropalatal retroglossal areas, apneic airway, upper airway. This is the dynamic of sleep MRI. So investigations for surgical patients, dynamic of sleep MRI, DICE, drug-induced sleep endoscopy by the ENT surgeon. Facial capillary is a very important test to rule out craniofacial abnormalities like retro and micrognathia. Hormone evaluation is very important. CTPNS is very important test before any surgical evaluation of the patients. The various kinds of surgery done by the ENT surgeons. Nasal surgery, tonsillectomy plus or minus adenodectomy, radiofrequency volumetric tissue reduction, expansive laryngoplasty, linguoplasty, genioglasses and higher advancement, sliding genioplasty, maxillomandibular advancement osteotomy, and tracheal. The various surgical options are available. You have to choose the patient meticulously. This is an 8-year-old boy presented with mouth breathing and snoring, daytime tiredness, sleepiness, very poor academics in the classroom. Reason behind is the huge tonsils and adenoids. This is the culprit. Patient underwent surgery. After that, dramatic improvement in the academic performance. This is maxillomandibular advancement osteotomy for retro and micrognathia. Bariatric surgery, BMI more than 35 or 37.5. We have to get the opinion from the bariatric surgeon. We have bariatric medicine. There are effective medications available nowadays. Is tirzepatide. Tirzepatide is a novel drug, synthetic polypeptide and dual agonist for glucagon like peptide 1, GLP-1, and glucose-dependent insulinotrophic peptide, polypeptide, that is GIP receptors agonist. Therefore, the drug leads to significantly improved glycemic control and weight reduction in patients with type 2 diabetes, maximizing benefits similar to the GLP-1 medications such as semaglutide. Nowadays, the semaglutide and tirzepatide plays a major role in weight reduction apart from the lifestyle modifications like diet and exercise. The key take-home messages: sleep apnea, that is OSA, is a condition which is highly prevalent across the globe, with India being one of the top countries in OSA prevalence. Timely diagnosis and management of OSA is imperative to avoid further complications in this patient. The level 1 sleep study being gold standard, home sleep apnea test has been seen to be the cost-effective and convenient option for high pretest score, no other comorbids, and no other associated other sleep disorders. Treatment is multidisciplinary. PAP therapy is the first line, and non-PAP therapy, which includes the oral devices, maxillomandibular advancement, and surgery, ENT head and neck surgery, maxillomandibular advancement osteotomy, and bariatric surgery. AI plays a major role in all the departments. AI, artificial intelligence in sleep medicine, precision sleep medicine, both diagnostic and treatment purposes. It does a lot of things. We feed the data, it will give all information, what kind of differential diagnosis, how to proceed, what kind of options. AI will throw light on that. Again, we have to be a doctor, we are the judge. We have to keep in mind that we have to take what kind of treatment. Treatment is individualized, depends upon each based on phenotype and endotype. So with that, I conclude my talk. We have a sleep med IMA course under the IMA AMS. I am the course coordinator. This 6 months course. Those who are interested in sleep medicine, kindly join. This is the future conference next month at Ahmedabad from 21st to 23rd August. This will be our 8th international conference on sleep disorders. Welcome to register, join, and you can get a lot of update on sleep medicine and sleep surgery. We have 6 kinds of workshop pre-conference. Welcome to join this. Thank you. With that, I conclude my talk. Any questions, I'll be happy to take. Thank you.
Thank you. Thank you, Dr. Jayaraman, for that excellent presentation. I think he has beautifully reminded us that OSA is much more than snoring. It is multi-system disease with important, multi-system involvement like cardiovascular, metabolic, neurological, and early diagnosis can transform patients' quality of life. And of course, we need a multidisciplinary approach to this disorder. And of course, the modern era is phenoendotyping, as I just told you about asthma and COPD. Here also, phenoendotyping is very, very important, and precision medicine and tailoring treatment to individual patients is very, very important. So can we take 1 or 2 questions from the chat box, Dr. Jayaraman? we'll take quick 1 or 2 questions because we are short of time. Okay. What is the first question? Okay.
Doctor is asking a link for the course. Yeah, I will update the course in our WhatsApp group.
Yeah, is obesity necessary to diagnose OSA? That's one question. Is obesity necessary to diagnose OSA?
In adult patients, we come across any obese patient, we have to rule out obstructive sleep apnea. Provided you have to ask questions to the bed partner about the sleep history. So, without symptoms, also patient may have the sleep apnea (OSA). So, any obesity is one of the risk factor to develop all kinds of disease. Obesity itself is a disease, it's a chronic disease. We have to rule out OSA is there or not by doing the sleep study to confirm whether patient has a obesity phenotype of the obstructive sleep apnea in adult population. In children, you know very well, AT, adenotonsillar hypertrophy, is a major phenotype. In adult, the major phenotype is apart from the craniofacial abnormality, obesity is one of the important phenotype. You ask the patient directly, do you have any snoring? Do you have excessive daytime sleepiness? Patient say no. You ask the bed partner, yes, doctor, my husband is having very snoring, heavy snoring. Then we have to correlate and do the testing. Even without symptom, there are a category called the asymptomatic OSA. We have to go and do the sleep study, confirm. These are silent cases we have to do and start the treatment to prevent unnecessary morbidity and mortality.
Yeah, thank you. So, 20 to 30% of OSA patients are non-obese patients. Again, you have to phenoendotype. Non-obesity, as he rightly pointed out, can have craniofacial anomalies from the upper respiratory tract and things like that. There are physiological phenotypes which we should not forget, like high loop people or low arousal threshold, meaning even for a small obstruction, they will try to get up. So things like that, phenoendotyping is very important if your patient is non-obese. This is where the phenoendotyping plays a major role. Obesity is a modifiable risk factor for OSA, that we should remember. So the next question is, should all people with snoring be evaluated for sleep apnea irrespective of age and comorbids?
All that snore is not OSA, like all that wheeze is not asthma. So we have to assess the risk factor, risk stratification. We think in terms of other comorbids like diabetes and other things, definitely we have to do the sleep study and find out whether patient has a OSA or not. Yes.
Yes, so I think snoring and some comorbidities or risk factors associated, you definitely need a sleep study. Primarily, only snoring doesn't call for detailed evaluation. Of course, if you have obesity there, you can have, it's a modified risk factor. If you correct that, they're going to be all right. So that's one thing. So I think for short of time, we'll move on to the next topic. Now, from the silent disorder of sleep, we'll return to India's old public health challenge, which is very, very important across all specialties. Everybody being a doctor, you should know about tuberculosis and how to treat tuberculosis. It's a disease that continues to evolve despite decades of progress. We are having an over-ambitious target of achieving TB control. So let's invite Dr. A.R. Gayatri Devi, a dear friend and an excellent pulmonologist, a senior pulmonologist from Apollo Hospitals, who will deliver the TB update. Dr. Gayatri is a senior consultant pulmonologist, a chairperson for IMA AMS Villivakam Ainavaram branch. She was awarded the Best IMA Chairperson and Best IMA Chapter Award. She has several orations in IMA. She's a faculty in Timocon, NAPCon, Broncon. She has many accolades here. She's a life member of various societies, and she was the organizing scientific chairperson for our 7th CSM. Dr. Gayatri, over to you. Dr. Gayatri, is she there? Dr. Gayatri?
ma'am is coming in the line now. Just I will return. Juliet ma'am, make the Gayatri ma'am as a co-host.
Oh, okay, sir.
Make the Gayatri ma'am as a co-host. I will call her.
Madam, we have given a request.
Is she there online or?
Yes, madam. She is online. I have given a request to unmute. She has to unmute, madam.
Oh, okay, okay.
Thank you so much, Dr. Tilaka, for the kind words of introduction. And thank you, AMS and Dr. Jayaraman, for this invitation to give this talk here. Are you able to see my slides?
Yes, I am able to see your slides.
Is it coming in full screen?
No, not full screen.
No?
No, not yet. I can see the left side slides also. Make it full screen. Yeah.
No, I have kept it full screen now.
Oh, okay.
Is it full screen now?
No.
Madam, can you just close the PPT, reopen the PPT and then slide share, madam. Already if it is in slide share mode previously, before sharing, it may not come.
Okay, sir. Is it seen, sir?
Slides are seen, but not
Yes,
full
madam.
screen.
Now it is seen. Now you can go for the full screen view, madam.
Is it now coming full screen, sir?
Not yet, madam. I'll just wait. I can see that you have pressed the button, but it has not come yet.
So double click, madam.
Maybe you can go to the top end, madam. Home, insert, design, animation, slideshow. There you can press the slideshow.
Yeah. To animation slideshow, click button.
Top left hand
Home,
corner.
insert, slideshow. Home, insert, from that button you click.
No, I'm already where home, insert,
Design,
slideshow.
animation,
Okay,
slideshow. Yeah.
slideshow from the beginning, huh?
Yes.
Yes, madam. From the beginning.
Okay,
Yeah.
now, sir?
Press it, madam.
No, I pressed it
Did you
already.
press?
Yes, I pressed
Press
it.
this.
But
Okay.
it's not full screen. I think it's okay. You present like that, Gayatri. The next
Okay,
slide.
madam. You can start. Yeah.
Okay. So, good evening, everyone. This is a brief update on TB. As all of you know, TB is one of the leading infections in the world, which has a very high mortality as a single disease, which can have such a catastrophic end. And unfortunately, TB is still the national disease of India. So I think we need to know a little bit more about TB and be updated so that we can tackle the disease and bring it to an end, as what the national and global forums are after. So everything started in 1882 when Robert Koch discovered the acid-fast bacilli. But despite being discovered so many years ago and the treatment also being initiated, still TB has the run of the world. So we talk about global statistics. It is such a widely spread disease with new infections, about 10.7 million people worldwide, with predominantly male
Gayatri,
predominance.
sorry to interrupt. Move your slides. You're not in the global burden slide. It's still on the first slide.
I've already moved it.
It's not moving, that means.
I've already moved it now.
No, it is first on your TB update first slide only. It's not moving at all. Now it's moving. Yeah. Now it's
No, this is
moving.
the smaller version now. This one, is this smaller version or big version now for you?
Smaller version.
Okay, now the slideshow, this is smaller or big version?
Smaller version.
The big version is not moving actually.
Okay, we can see this. You can go ahead.
Okay, fine. For me, it's a big screen.
Okay.
So with the mortality of about 1.23 million deaths per year, and about 25% of the global population is estimated to have latent TB. Among all the incident TB cases, 5.8% were among people living with HIV. And TB is the world's leading cause of death from a single infectious agent. And if you see the world map, predominantly with the number of cases seen, it is more in the Asian countries, especially in India, Pakistan, Bangladesh, China, Philippines, scattered over the African continent and a little bit over the South Americas. And 2/3 of the global TB cases, 8 countries topped the list, topped by, unfortunately, our own country, India, followed by Indonesia, Philippines, China, Pakistan, Nigeria, the Congo, and Bangladesh. And about 1.8 million deaths were there due to TB in patients without HIV, and about 150,000 deaths among patients with HIV. And with Robert Koch's identification of MTB in 1882, it opened the advances in the diagnosis and treatment of TB. So we have a World TB Day commemorating the discovery of TB, and this year's theme was Yes, We Can End TB, led by countries and powered by people. So it has to be a group effort led by the governments and also by all the administrators and the people. Only then we can go towards the path of ending TB. It highlights the importance of government leadership and community involvement in eliminating TB. And in this occasion of World TB Day this year, the Forum of International Respiratory Societies and the Global Initiative for Asthma, they started to urge governments and international agencies and the global health community to prioritize evidence-based strategies to stop TB, especially the transmission, and to accelerate the progress towards ending the disease. So everything is focused on trying to prevent the transmission and spread of the disease, and also to aim towards ending the disease as well. And it is also, this forum has called for implementing community-wide screening in the high burden settings with technical and community guidance, expanding access to modern diagnostics and effective treatments, strengthening accountability for sustained reduction in TB incidence. Yeah.
The slide is not moving. Adjust slides move. Global burden of TB தான் இருக்குது.
இன்னும் global burdenல இருக்கா?
Slides கொஞ்சம் move பண்ணுங்க. Slide move பண்ணுங்க.
Shall I put it a small screen and then it moves?
Now it moves. Yeah.
Okay. Is it visible to you, the small screen?
So small letters.
Yeah. No, that's what, I don't know. It's not coming as a big screen. Shall I try that slideshow again? Is it visible now for you?
Full slides click பண்ண வரணும்.
No, this is a full slideshow of the.
உங்க சைடுல full slides தெரியுது, but எங்களுக்கு பார்த்து மற்ற சைடுல அந்த ஸ்லைட்ஸ்ல வரும். மற்ற ஸ்லைட்ஸ்ல தெரியுது எனக்கு.
You are seeing the full slides, Dr. Gayatri?
Yes, I'm seeing a full slide actually.
Oh, okay.
But Mukesh advised by clicking the close button on left side next to the outline box, we can maximize the screen put.
What is it?
In the chat box, by clicking the close button on left side next to the outline box, we can maximize the screen.
I can't even understand what he's telling.
Madam, are you able to hear me, madam?
Yes, Dr. Ibrahim. I am able to.
Yes, madam. Actually, what is happening is your computer has now 3 screens. One is the PowerPoint screen, one is slideshow screen, one is the normal desktop screen.
Okay,
so
sir.
Your PowerPoint screen only we are seeing, not the slideshow screen. So what you have to do is go to the slideshow. What you are doing, press escape key and come out of the slideshow first.
How do you want me to escape? Okay.
Now your full screen has come down. It is off.
No, sir, I'm not able to get it. This one now it's full screen, small screen only now.
No. Your slideshow has gone, madam.
Slideshow, I'm not in the slideshow, sir.
No. You said you are in the full screen, no?
No, this is
Get out of the full screen. That's
no,
what he's saying.
this is a small screen.
Okay, in the
your
laptop.
computer, are you out of the slideshow?
Yes, I am out of the slideshow. I am only in a small screen.
Okay,
madam. Can you just press Alt and Tab button together? Alt and Tab button. In your keyboard.
Okay.
Alt and Tab together.
Yeah.
Together. What you are seeing in the screen, madam, now?
Small screen, sir.
No. How many screens? What are the screens you are able to see?
Only one screen I'm seeing, Alt and Tab.
Alt and Tab, only one screen is coming.
Yes.
Yeah, just click that screen alone.
Yes, sir.
Okay, now go to Zoom and stop slideshow and then restart now again.
Okay, go to Zoom. Huh? Okay.
Zoom, yeah.
Should I stop the share?
Stop. Yes, madam. Stop it.
Okay. Share
Yes.
Share it once again, is it?
No. Now you open the PPT now.
If I stop sharing it, how will it come to you then?
No. You stop
First
sharing.
completely close the PPT.
Close the PPT.
Okay, close the PPT. Okay.
PPT is closed now.
Yes.
Yes, madam. Now you open the PPT.
Now open the PPT again. Huh?
Yeah.
That is the background PPT, is it?
Yes.
1 minute.
Stop. Yeah.
1 minute. Tell me, ma'am. Hello. Okay, I opened the PPT.
Now you start sharing, madam. Press slide share.
Share the slide, yeah.
Yeah.
Yeah, got it.
We have not seen the slides here. Right?
Are you able to see now, sir?
It has started, madam. 1 second.
Yeah.
Now go to the top end, madam. Left hand top corner. You can see slide share is there. Yes.
Slide share, I've already shared it, sir, no?
No, madam. Can you just press it now?
It's already shared. It's already shared.
Now you are seeing full screen on your computer.
No, it's a small screen.
Okay. Now you press slide share. It's not going up.
I've already shared the screen. It's coming on your screen.
Now go to
slide share, madam. That slideshow. Yeah.
Slideshow.
Yeah.
Slideshow.
Press slideshow now.
Okay.
From the beginning. Yeah.
From beginning. Okay. Are you seeing a big screen now?
We are not seeing, ma'am. It may come.
Are you seeing a big screen now?
No, madam. Okay, you do one thing, madam. Go to the right down corner. You can see some 58% is there. Can you make that bigger?
Where is that, sir?
Right hand lower down corner.
I'm not able to see any other.
No, madam.
Plus sign is there, no?
In your screen, bottom right hand corner.
Okay.
There.
Yes.
That's
no, reduce it a little bit. Reduce it. Like
it just
fine.
Yeah. That should be fine.
Now you come to your slide.
This is okay for you?
Yes.
This better.
Okay, better.
Thank you.
Okay, are you seeing it fairly big now?
Yes.
Finally.
Not moving, I think. Okay, now it's fine.
Is it moving for you now?
Yes, ma'am.
Yes.
TB diagnostic methods, is that displayed now for you?
Yes, yes.
Okay, right. So when we talk about all the diagnostic methodology available to us for diagnosing TB, we shouldn't forget that some of them have high sensitivity or not or specificity. So we just go through what's available to us. The sputum sphere microscopy for AFB smear, high sensitivity, high specificity. It's very widely available, it's cost effective. Culture is a gold standard with a high specificity, sensitivity and specificity. Then we have the gene expert rifampicin resistant detecting methodology. It's a molecular test which detects the TB bacteria and also detects the rifampicin resistance using the PCR technology. It has a very high sensitivity as well as a high specificity. And you can detect the early onset of any rifampicin resistance. So it is a very important test, and it has also been highlighted in the present National Tuberculosis Elimination Program to do a upfront drug sensitivity testing. So this is the test which you have to order for in the beginning itself, not in the down the line. Then you have the nucleic acid amplification tests, which are also rapid and highly sensitive methods for detection of TB. The line probe assays, these are genetic tests that detect the drug resistance, especially the mutations in the TB bacteria to diagnose MDR TB, and they help in the setting up the drugs which we need to choose for the treatment of the TB. And we have something called whole genome sequencing. This is a comprehensive genetic analysis of the complete genome of TB bacteria, which allows for detailed strain characterization, and it enables the detailed understanding of the TB strains and the drug resistance. We have another test called the Expert MTB RIF Ultra. This is an enhanced version of the Gene Expert MTB RIF, and it provides increased sensitivity for detecting TB and rifampicin resistance, and it improves the sensitivity for TB detection and drug resistance detection. Then you have the LAMP, the loop mediated isothermal amplification. It is a rapid molecular diagnostic technique that amplifies specific DNA sequences of TB bacteria under isothermal conditions. It is a simple and cost-effective method with potential for point-of-care use. We shouldn't forget our good old chest X-ray, which is a non-microbiological investigation, has variable sensitivity, this one. It provides visual evidence of TB-related abnormalities. Obviously, we can't confirm TB with the chest X-ray. We can just identify that as an abnormality. A TST is widely used, but it cannot differentiate between the latent and the active TB. DIGRA or the TB Golds, these are tests which can help to differentiate between latent and active TB infection. It's basically a blood test. Then you have the molecular drug susceptibility testing, which is a molecular test that determines the susceptibility of the TB bacteria to various anti-TB drugs. It helps in the selection of the effective anti-TB medication. And how you can take the samples other than sputum analysis, we can take samples through a bronchoscopy, or if there's a pleural collection, we can take samples from the pleural fluid and analyze it. So when you talk about TB, we have to find out whether it's going to be a drug-sensitive TB or a drug-resistant TB. A drug-sensitive TB is defined as TB susceptible to both isoniazid and rifampicin. The WHO recommended regimen of DSTB is 6 months oral course of 4 drugs in 2 phases, 2 months of HRZE and 4 months of HR, that is 2 months of isoniazid, rifampicin, pyrazinamide and ethambutol, and 4 months of isoniazid and rifampicin. And they give it as 2 phases, the intensive phase of 2 months and the continuation phase of 4 months. And they also recommend that if fixed dose tablets are available, they should be used. Our National TB Elimination Program actually mandates the universal drug susceptibility testing upfront. So that's what they really emphasize. And they recommend the regime of 6 months all oral therapy of 4 drugs in 2 phases. That is 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid, rifampicin, and ethambutol. And the fixed dose combination drugs are given as per the weight band. And the latest guidelines for the TB, for the diagnosis and treatment of TB are based on WHO guidelines, CDC, ATS, ERS, and IDCA guidelines. And it focuses on rapid diagnosis of TB using a shorter regimens and all oral regimens, also emphasizing reduced toxicity and use of injectables so that there will be better adherence and outcomes to the therapy. When we talk about what are really new in the diagnosis, in the treatment of TB, we have the shorter version of the therapy, which is restricted to about 4 months. That is, rifampicin is replaced with rifampicin, and in addition, ethambutol is removed from the regimen. So you have an intensive phase therapy of daily isoniazid, rifampicin, moxifloxacin, and pyrazinamide. And the continuation phase is used with isoniazid, rifampicin, and moxifloxacin. Our NTP still uses our regimen of the old 2HR EZ regimen and the 4HRE. We have not come to this regimen yet. When you talk about what is drug-resistant TB, MDR TB is TB resistant to both isoniazid and rifampicin. And rifampicin-resistant TB is TB resistant to rifampicin, but it is susceptible to isoniazid. So the WHO treatment guidelines for MDR TB suggests a 6-month therapy in non-pregnant persons over 14 years using bedaquiline, pretonamide, levofloxacin, linezolid, and moxifloxacin, or the use of the other regimen which has instead a clofazimine, which can be used for patients of all ages, including those who are pregnant and breastfeeding. They can also stop the use of clofazimine can be stopped from the regimen if fluoroquinolone susceptibility is confirmed. So in patients who are ineligible for the 6-month regimens, the standard 9-month all oral regimen or the modified 9-month all oral regimens can be also used. So from 2021, the WHO also revised its definition of XDR-TB to reflect the reduced reliance on injectable agents due to the growing concerns that the newer drugs are also getting resistance, including bedaquiline resistance, which in countries where they don't have access to proper genotypic DST. As of now, bedaquiline is widely available only in the government sector. Private, I think only one company is highlighting the sales of that drug. But I think as a very precious drug, it should not be misused because with such a rampant prevalence of drug-resistant TB, it has to be used with caution and protected so that resistance does not come due to the misuse of the drug. So XDR-TB is now defined as TB resistant to rifampicin, a fluoroquinolone, and one additional group A agent, that is either a bedaquiline or linezolid. So the BPAL-LM regimen. So you use bedaquiline initially in the 400 mg once daily regimen for about 1 to 2 weeks, and after that use 200 mg 3 times a week, plus pretominid along with the linezolid and moxifloxacin. And additional pyridoxine has to be given as per the weight band. It is used at a higher dose compared to the other pyridoxine, which is used in standard ATT regimens. The 9 to 11 month shorter oral MDR regimen, linezolid, levofloxacin, clofazimine, pyrazinamide, ethambutol, isoniazid at a higher dose, and bedaquiline are used in the initial phase, followed by levofloxacin, clofazimine, pyrazinamide, and ethambutol. So the doses of the drugs which can be used as per the weight band has been displayed here. The doses of the isoniazid use is at a higher dose than what we use normally. So up to 30 kilo, 29 kilos, we use 300 mg. But more than that, for each weight band, we are using higher and higher doses of isoniazid up to a maximum of 900 mg. And the other drugs are all weight-based. And as already mentioned, the bedaquiline dose for the only initial 2 weeks, it is 400 mg daily. After that, it is 200 mg 3 times a week. And the dosage of pyridoxine also is much higher than what is standardly used in the treatment of drug-sensitive TB. The longer oral regimen, basically they categorize drugs into 3 groups. Group A includes all the medicines, levofloxacin or moxifloxacin, bedaquiline and linezolid. Group A is clofazimine, cycloserine or terazidone. And group C is ethambutol, pyrazinamide, meropenem, amikacin, ethionamide or PAS. So we have to do a selection of drugs based on the group. And it really means that giving about 6 months of bedaquiline and longer duration of levofloxacin, linezolid, clofazimine. And the dose I've actually mentioned here. The higher the doses are all as per the weight band. Up to 29 kilos of a particular dose, from 30 to 45 another dose, and more than 70 kilos they have a standard dose which we will follow. Some things we need to also know in our treatment of TB is about isoniazid monoresistance. This isoniazid monoresistance can be at a high or a low level, and it is associated with mutations in the CATG gene or the INHA genes. A high-level resistance is mostly linked with mutations in the CATG gene. Low-level resistance is mostly linked with mutations in the INHA promoter region. When you have a high-level INHA resistance, they might be more involved with pan-drug resistance, so making the MDR TB treatment regimens a little bit difficult to formulate. And in the global scenario, when you talk about INH resistance, in the new cases, it happens about 7 to 10% in the new cases. And in the previously treated cases, it happens about 11 to 27%. But in India, the incidence of INH resistance is very high. In new cases itself, it is more than 11% and up to 25% in the previously treated cases. So in these kind of scenarios, we have to be mindful of the treatment. The WHO recommendation is a 6-month regimen of rifampicin, ethambutol, pyrazinamide, and levofloxacin for the treatment of isoniazid-resistant TB. There is no separate intensive phase or continuation phase. It is a daily therapy. So this is the dosage of the drugs used for the isoniazid-resistant drug-resistant TB. As per the weight band, the rifampicin dose is increased, as well as the ethambutol and levofloxacin. And when all these drugs are used, obviously we have to be monitoring the liver function test. And when ethambutol is being used, we have to even check the visual fields for any ethambutol toxicity and also warn the patients if there is any ethambutol toxicity possibility is there. There are certain situations that levofloxacin or pyrazinamide can't be used. So at that time, we replace it with linezolid. And if linezolid also cannot be used, we replace it with clofazimine. If both levofloxacin and pyrazinamide can't be used, we have to add 2 more drugs in the order of preference based on the resistance, tolerability, and availability. If the rifampicin is having a resistance, we switch to another therapy. And all this is based on drug sensitivity availability. So this is just a summary of what has been discussed about drug-sensitive TB and the newer drug-sensitive TB regimen of 4 months only, which contains the rifampicin, isoniazid, pyrazinamide, and moxifloxacin, the standard therapy which we are all familiar with. This is the WHO recommendation, but as per the NTP, we use 2-HREZ and 4-HRE. And these are the regimens or the isoniazid resistant TB, the MDR rifampicin resistant TB, that the BPAL-M regimen, and the rifampicin resistant TB 6-month regimens, and also the 9-month regimens. It has to be emphasized that all these regimens are all oral regimens. And that is what the emphasis is on. So there will be better compliance, adherence, and the risk of side effects will be less. And a few words about TB preventive therapy. When you talk about TB, not only do you have to treat the disease, we also have to see we have to prevent and how we can prevent the disease. And that's where the role of TB preventive therapy has come in, especially for patients who have household contacts, patients living with HIV, the vulnerable group of patients, to prevent the infection from progressing to active disease. The regimens range from 6 months of only isoniazid daily or rifampicin and INH daily, or a weekly rifampicin dosage. Obviously, patient support is equally essential. Nutritional support has to be given, and the government's Nikshay portal has the option of direct benefit transfers coordinated so that money gets into the patient's account so they can have a better kind of nutritional support and support for their loss of their economical loss due to them being off work due to the disease. So these are things which are really essential. We have to work together to prevent the disease. Patient has to take the medication, patient has to be supported nutritionally, and also have a bit of financial support as well. So just emphasizing a few of the key take-home messages. NTP program emphasizes on rapid molecular diagnosis. Short regimens are now widely used, and even the earlier MDR TB regimens which we had earlier, which were about 18 to 24 months, now have been really shortened with the introduction of bedaquiline. 6 months is the shortest regimen. All oral MDR TB therapy is a major shift, and individualized drug-resistant TB therapy is very essential. Thank you. If there are any questions, I'll be happy to take them. I can't hear you. I can't hear you. Dr. Tilak, I can't hear you. Unmute.
Sorry. Thank you very much for your valuable insights, Dr. Gayatri. I think TB care today is no longer about prescribing only 4 drugs. As you rightly pointed out, it is about rapid molecular diagnosis, individualizing the treatment, having a drug-resistant profile upfront, ensuring that your patient is not a drug-resistant patient, and instituting appropriate therapy so that, and also the follow-up of patient adherence and preventing transmission. I think that's the key to any tuberculosis patient's treatment success. So for want of time, we will take one question from the chat box. The question is tuberculosis overdiagnosed and undertreated?
I would say it's underdiagnosed and overtreated sometimes. I would put the reverse actually. Because many times I've had patients come in with all sorts of investigations other than taking the patient out for TB. So I would say it's underdiagnosed. TB actually is like a master at deception. So it need not be that we see the standard radiological presentation. Sometimes it might even present like even a tumor-like presentation. We've had patients being investigated up to even PET CT and biopsies also, because there were so catastrophic findings in the PET CT finding that we were thinking of a malignancy. But when we finally did the biopsy and the microbiological analysis and the gene expert, we found that it was TB. So I would say it's underdiagnosed. Sometimes you might not even think about it. So in this day and age, and still in our country, especially in diabetics, I think we still have to keep it on mind. And about the over treatment, I would say some of the times I see very, very peculiar prescriptions coming in, be given to patients, an underdosing of the standard TB drugs, or some of the drugs being missed out, or the drugs being given at different times of the day. That's why I emphasized in the presentation about the weight-based prescriptions, because that is really essential key to the patient's disease being controlled and brought under to a cure state, and also towards disease eradication. If you start undertreating the patient or giving them less dose of the standard TB medications when they have a drug sensitive TB, you might be actually promoting resistance. So that is going to be problematic to deal with, rather than treating them first up, the first chance with as a drug sensitive TB.
Yes, thank you very much for that wonderful answer. I think the message from what she said is there is no role for empirical ATT in this scenario in our, in the 20th century. Please go all out to do the molecular diagnostics, confirm tuberculosis, confirm or rule out drug resistance, and then start treating the patient. So I think thank you, Dr. Gayatri. For want of time, we'll move on to the next talk.
Right. Thank you so much, Dr. Tilaka and Dr. Jayaraman. Thank you. Thank you, AMS.
So we'll move on from infection to innovation, from treating disease based on appearance to treating it based on its molecular signature. So it is about lung cancer. Our final speaker will discuss one of the most exciting areas in lung cancer. He's going to talk on lung cancer update. It's my pleasure to invite Dr. Sridhar, who's a conventional interventional pulmonologist from MGM Healthcare. He has he's associated editor in Journal of Association of Pulmonologists of Tamil Nadu. He has published more than 20 articles in various index journals. He was awarded the gold medal from Association of Pulmonologists of Tamil Nadu. He has been a part of organizing committee and faculty in various conferences. It's over to you, Dr. Sridhar. The floor is yours.
Okay, ma'am. So I thanks IMA and Dr. Jayaraman sir for giving me this opportunity. So I just share my screen. So able to see my screen, sir? No?
Yes,
Just put it.
yes.
Okay.
Go to presenter. Yes, we are able to see. Please go ahead.
Yeah. So just updating the lung cancer. So lung cancer is a big topic. So the upcoming month we are going to have a lung cancer day. There we are having a whole day to discuss about lung cancer. So I'm just touching upon the only important silent points now. Just moving on to that. So the burden of lung cancer. That is the first thing we need to know. The lung cancer is most often diagnosed cancer and leading cause of cancer-related deaths worldwide. And the lung cancer accounts for 5.9% of all cancers and 8.1% of all cancer related deaths. According to the estimate, the number of cancer cases rises by 12.8% in 2025 compared to the 2020. It means 1 in 9 Indian will probably get cancer at some point in their lifetime. See, so how common this is going to be because of the newer lifestyle modifications as air pollution, all this. So we move on to the risk factors for the lung cancer. We know everyone knows obviously the smoking. So the lung cancer associated with the smoking, the 80% of the lung cancer, the smoking is the risk factor. The package we used to calculate to know the severity of this risk of the smoking. So number of packages smoked per day in 2 years of smoking, usually more than 20, you come into the high risk category, you need a screening for lung cancers. See, other risk factors, the family history of cancer, that is also any cancer, not only the lung cancer. So you also need a further screening, all this, that is also one of the risk factors. And occupational exposures to cancers, you know very well, asbestosis, silica, coal dust, cadmium, nickel, any matter, any chemical can cause a lung cancer. So, and next is the radon exposures and air pollution. So nowadays, everywhere we are speaking about air pollutions. Though the air pollution per se is not included in the lung cancer screening program, but air pollution is one of the significant risk factors, especially in the major polluted cities and those who are staying in the nearby major roads on polluted areas are the risk for the lung cancer. Another one, this is most many of us will forget the history of lung disease like COPD, pulmonary fibrosis also can lead into the lung cancer in years. Okay, so these are the risk factors you should keep in mind, and we have to follow up the patients. The lung cancer screening. So when there is a risk factor for the patient, we have to do the lung cancer screening. We move into the lung cancer screening part. So the screening for the lung cancer is finding the lung cancer early enough to allow for a curative treatment. See, most of the time the lung cancer becomes symptomatic. That time the stages will be a 3 or 4. That is, we can't afford no longer a curable treatment. If you pick up in early stages, we can do a 90% curative treatments are possible. Okay. To enhance the lung cancer outcomes, the lung cancer screening is essential. Okay, so how we can do a lung cancer screening? The recommended is low dose CT chest. What is low dose? This amount of radiation exposed in the low dose CT is much less than the standard CT is half the radiation you are exposed to naturally from the environment. So it's safer. So that we recommend it. So why not just simply chest X-ray alone is not enough. There are multiple trials they have conducted for lung cancer screening. They all suggested the low dose CT is better results compared with the chest X-ray. That significantly lowers the cancer mortality 20% by doing a lung cancer and screening by low dose CT and picking up early. We can reduce the mortality. So, who are all eligible for lung cancer screening? So, age more than 50 and smoke with past years more than 20 years is as per the guidelines. They are the one should undergo lung cancer screening every year. See, lung cancer screening eligibility, as I said, age more than 50 to 80 years, and the smokers with current smokers are quit within last 15 years, 20 back years smoking history, or this is the additional thing. This is recommended along with that any other risk factors like family history, occupational exposures also better to undergo a lung cancer screening. See, once we do a lung cancer screening, the baseline low dose CT based on the findings, we'll move forward. If you're finding a lesion of less than 8 mm or 6 mm, just we need a follow-up. Or if you find some mass are bigger than 8 mm, we need to do a further investigation like PET scan or something. If the low dose CT is normal, then every year we have to do a follow with the low dose CT lung cancer screening. It's not end with one-time screening. Every year we have to follow. Okay. So in follow-up, if you get a based on the nodule size and nodule character, we'll schedule the follow-up scan or work up with PET scan. It's all based on the guideline recommendations. So I'm not moving in detail about all this. It's all available. It's all even if I say every time you have to refer the guideline, it's very difficult to remember. Okay. So then after the lung cancer screening and moving on to types of lung cancer, just touching upon its non-small lung cancer and small cell lung cancer is widely we are classifying because small cell lung cancer has a worse prognosis compared to the non-small cell lung cancers. And many targeted therapies are available for adenocarcinoma and then squamous cell carcinoma where mostly chemotherapies. Now we can give some immunotherapies and then large cell carcinomas. So the most common is uh, adenocarcinoma followed by squamous cell and then small cell and then later large cell carcinomas. See the key symptoms, the chronic cough or changing in the character of the cough over the months or over the days, and hemoptysis, shortness of breath, chest pain, especially persistent, dull aching, and unexplained weight loss and fatigue, difficulty in swallowing or hoarseness due to this compressive symptoms, and recurrent lung infection, sometimes the obstruction, post-obstructive pneumonitis, and symptoms of metastasis such as bone pain, jaundice, and error. These are not these signs. These signs can be lung cancer, so we need to work up or should not ignore the symptoms and just treat with simply empirical things. We have to work up further with the imaging to rule out the lung cancer. And next is the weird symptoms, paraneoplastic symptoms associated with lung cancer. Sometimes this can be the presenting symptoms. Not always, sometimes. So, what are the paraneoplastic syndromes associated with lung cancer? Hypercalcemia, especially in small squamous cell carcinoma, SIDS, syndrome of inappropriate in antidiuretic hormone secretion, and Cushing syndromes, Lambert-Eaton myasthenic syndrome, neurological syndrome like cerebral degeneration, encephalitis, sensory neuropathy, coagulation disorders, dermatomyositis, polymyositis also can be a paraneoplastic syndrome with lung. And in HPOA, that last stage of clubbing. And superior vena cava syndrome, well known, it is associated with mediastinal masses and centrally located lung cancers. Horner syndrome, yeah, Pankers syndrome, and carcinoid syndrome, and cancer cachexia. See, all this can be paraneoplastic syndromes due to the lung cancers. So, next, after the symptoms, what are the diagnostic tools in general for lung cancer? So, first, the first one we do is imaging. So chest X-ray, it's a common, but those chest X-ray sometimes with a larger mass or something we can pick up in chest X-ray, either the patient present with symptom or even in the many times we pick up in master health checkup. The next is CT scan. Already I said low dose CT scan for screening, otherwise for workup, CT scan or PET scan. MRI mainly for metastasis or some mediastinal lesions or something, brain metastasis. All this we can use MRI. But nowadays for the staging, most commonly we are using PET scan and tissue biopsy and cytology. So once you do imaging there, you identify some mass or suspicious of lung, we have to confirm. For that we need a biopsy. For that, there are the various methods we can do the biopsy based on the location of tumor. If more central or airway, we can do with the EBUS bronchoscopy. If it is more of peripheral large masses, we'll go with the CT guided biopsies. VATS nowadays, if it is not possible or inconclusive with bronchoscopy or CT guided, then VATS will utilize to do a biopsy. And thoracoscopy, especially in patients, someone with malignant pleural effusion, we have to do a pleural biopsy. And laboratory tests, sometimes the sputum cytology, but the yield is very, very poor, generally not recommended. Blood test, from the blood test, we can pick up, so as I said, some paraneoplastic syndromes, other things, and liquid biopsies in follow-ups. Sometimes when we are not having adequate tissue, we confirm in follow-ups, we have to do further molecular studies or something when you are not able to obtain again another tissue or something, inadequate tissue, that time you can go for a liquid biopsy. And IHCs, you have to type the whether it's a primary or metastasis or what type of whether adeno or squamous small cell, for that IHCs are required. And molecular testing mainly to targeted therapies to initiate and targeted therapy, especially in adenocarcinomas. So based on that, we can start a molecular therapy, EGFR, ALK, RAS mutation. Now the molecular testing, the recommended is the next generation sequencing, whole NGS. That's what recommended. When it's not feasible or it's because it's non-affordable reason, we can choose and do based on the clinical profile. And the Rocco is also sometimes the fluid analysis, simple pleural analysis, pleural fluid cell block itself, we can give a yield. Cell block, if you have adequate cells, then we can go ahead with the molecular testing IHS in cell block also. That is also possible. So next, once we diagnose, next is staging. For the staging, we should know the mediastinal nodes, the N level, which is very important, playing an important role in staging. Okay, so we need to know the stations of nodes. That's a supraclavicular one, and then upper paratracheal, prevascular, lower paratracheal, aortic zone, subaortic, paraortic, and subcarinal. 7, 8 is paraxylate, 9 is inferior, and N1 zones, scalar, interlobar, lobar, segmental. So all these nodes we need to look. We need all this node status for the for staging of the lung cancer. So staging of lung cancer, the nodal staging playing a vital role because many times that is decides the stages based on the stages treatment, whether go for surgery or non-surgery. That is the important decision. So this TNM 9th edition, this staging, the TNM staging is we are using for adenosquamous all this. Small cell we are using different staging, extensive and limited. But commonly TNM staging is most commonly using for the non-small cell cancers. So the newer update is M1C1. The M1C, the distant metastasis, the distant organ metastasis. Again they classify as C1 and C2. the multiple extrathoracic metastasis in a single organ or multiple organ. So this all helps in further prognosis. All this sometimes the newer concept oligometastasis. So the only single metastasis outside the organ, then still it can, if there is no other contagious spread, we can still go for a surgery, the primary and oligometastasis lesions. And this is newer updations that because of the newer updates, many changes in the ninth edition. The N1, N2 status has been changed because mainly due to the node N2. That's forgot to mention the N2. N2 has been again classified as N2A, N2B, the single N2 station involvement, and N2B, the multiple N2 station involvement. This is helpful in deciding about surgeries. Even the N2A, we can go for a surgery. So that's why this N2A brought up here. So by using the N2A, many changes happening in the staging. You can see here N2A, N2B, they divided so that previously the 3A, all this coming down to 2B. Uh, so previously, once N2, we will call it as 3A, 3A, 3B. Here, even in N2, we are calling as 2B. This is all helpful in surgery. So we can go ahead with surgery. So again, this is a diagrammatic representation of the various stages based on TNM. Okay. Now we move on to, once we do the finish of the staging, then we are moving on to treatment options. Treatment options, the further, the earlier stages, obviously surgical treatment. Surgical treatment, it can be lobectomy, pneumonectomy. Even sometimes the small tumors, we are doing only wedge resections. Segmentum is also possible. In chemotherapy, first line usually the cisplatin based or carboplatin platin based, and second line gemcitabine pemetrexed. And radiation therapies, sometimes when surgery is not feasible, even the radiation comes in the security intent in the stage 1, stage 2, when surgery is not feasible. Palliative also we are giving, concurrent also we are giving, and the most thing is the targeted. The evolving field is targeted therapies. So EGFR, ALK, ROSE, all this is possible in adenocarcinomas. That's why we are doing the molecular testing. Based on that, we can start a molecular therapy. After the invent of molecular therapy, the survival rate is very well improved. And immunotherapy is PD1, PDL1 inhibitor. This is also, even they are using as a new adjuvant also nowadays. This is also plays a vital role in cancer management. That's why we need adequate tissue to do all the molecular testing, PDL1, all this. Just simply to say it's a carcinoma, lung adenocarcinoma, there the diagnosis is not changed. Further, for the management, we need a further tissue to do the targeted and immunotherapy studies. And palliative care in the pain relief, main thing, and palliative radiation for the bone, brain, and metastasis. And sometimes pleural effusion management also will come in the palliative care. And then supportive care, that all symptom relief and increase the quality of life. So, and now that's previously what I discussed in non-small cell. Now, small cell, we classify as stage as limited stage and extensive stage. In limited stage, the chemo, mainly the chemotherapy plays a vital role. There is no routine immunotherapy in the limited stage, but immunotherapy possible in small cell in extensive stages. If the PDL1 or something is positive, still we can use immunotherapy. Um, and this is the squamous cell. Squamous cell mainly chemotherapy, but here also immunotherapy roles are there. There is no role for targeted therapy. So in only in adenocarcinoma we have a targeted therapy. Small squamous cell and small cell immunotherapy. You may try immunotherapy. The PDL1 expression is high. Okay, so as I already mentioned here, only the targeted therapy role comes. It's mainly it increases the survival 50 to 70% stage 1 and 2 with surgery and adjuvant chemotherapy. So it's a multidisciplinary team approach. Always the lung cancer management, it's not only with the oncologist or not only with the pulmonologist. It's a or everyone, radiation oncology, thoracic surgeon, pathologist, pain specialist, and pulmonologists all need, that's why always we commonly have a practice of tumor board. So always we discuss all the cases in tumor board and get everyone opinion and proceed further. So that is if you compare with the pre-targeted therapy area in 2024, now the 2025, now current era, after the advancement of uh, molecular therapy, there is increase in the survival rate. Previously, see 55 to 65, now it's 90 up to 90 percentage. It plays a major role in stage 4. See, previously we used to say when we are studying, we used to say that the lung cancer stage C, malignant pleural effusion. That's all. We'll say only the survival rate is 6 to 8 months. But now we are seeing many patients are even 5 years, 38 to 60 months. They are with the advance of the molecular therapy. They are living up to 5 years. So this now we have changed our statement. Before once, as soon as we see the malignant pleural effusion, we used to say the survival rate is six months to 8 months. But now this increased because of advent of targeted therapy and immunotherapy. So the key message is the greatest improvement in lung cancer as not only from the surgery alone, but precision oncology, including comprehensive molecular profiling, targeted therapies, immune checkpoint, early detection. That's a very major role. So whatever it is, if you pick up the cancer in the stage 1 or 2 by the screening before the symptom appears, that is the curative intent, that is the real life for the patient. Then always multidisciplinary management. So thank you. Because of short of time, I rushed through my presentation, but I just touched upon all the points. Thank you.
Yeah, thank you. Thank you for that excellent update, Dr. Sridhar. Within a short time, as you said, there is so much. There are sea of changes in lung cancer in the last few years. I think you have given a bird's eye view about it. Like it's very difficult to cover this topic in a short time. Thank you very much for that. So, for want of time, let's take one question from the chat box. So there is an interesting question saying, what is the time limit for screening for lung cancer? I think you already explained. Can you briefly tell us about it?
Yes. So above 50 years until 80, 85 years, because after that, their lifetime expectancy is less. So time limit is every year we have to do the lung cancer screening from 50 years till 85 years, we can say.
One more addition to that is, I think 50, you said that 15 years after smoking cessation. So it is 50 to 80 years and 15 years after smoking cessation. So why did they stop with 80 years? I think you explained that because the ability to, cure the patient at that, the ability to have a curative treatment is less after 80 years. So that's why they stopped screening. Okay. Thank you very much, Dr. Sridhar, for that wonderful update. I think we have come to the end of our presentation and we are running short of time. So as we conclude this scientific session, I would like to express my heartfelt gratitude to all the distinguished speakers for sharing their expertise and their valuable clinical experience and also their valuable time. So in just 3 hours, we have traveled across the entire spectrum of pulmonology from infections, airway diseases, tuberculosis, and the lung cancer. The common thing here is that medicine continues to evolve, but our commitment to lifelong learning must evolve even faster. So every updated guidelines, every new diagnostic tool or some new therapeutic breakthrough, ultimately you will be aware of platforms like this where the IMA has taken so much pains to bring all the speakers together and enrich all of us with the knowledge. So I think talks like this or the webinars like this or the platforms like this help us in keeping us updated and to help our patients get curative treatment. Thank you very much for the active participation. Have a wonderful evening. Thank you, and over to the organizers.
Thank you, madam. Thank you for the wonderful moderation. Nirmal sir, do you have any words to share, sir? Sir, can you please unmute, sir? You're muted.
Sir, thank you very much for the wonderful opportunity. We had a wonderful sessions. I thank you, IMA AMS team and IMA leaders for the good platform to disseminate knowledge, and including as one of the important 5 days conference pulmonology. We had
Thank you, Dr. Jairam.
All thanks to your AMS team and leaders of IAB. Thank you, sir.
Thank you, Dr. Jairam and the entire pulmonology faculty for this wonderful session.
Yeah. Yes, sir.
Yes, Mohammed.
Yes,
I just want to thank all the speakers and Dr. Jairam sir for bringing this full day session, and it was like a quick revision of entire pulmonology in 3 hours time. And thank you, the entire faculty and all the delegates who joined us in large numbers for this important session. So do join us tomorrow for yet another interesting session related to ophthalmology. We have 7 talks and very good experts, starting from the President-elect of All India Ophthalmic Society, and a big list of speakers and panelists to give you a quick update on the entire ophthalmology track. So with this word, I hand over to Dr. Muhammad Ibrahim and request all of you to join us for all the subsequent sessions the next 3 days.
Thank you, AMS Chairman, Sir TNSP. So, on behalf of AMS, I thank our chief guest today, Dr. Jairam sir, who is President of Commonwealth Association, Commonwealth Medical Association, who was kind enough to attend the event in spite of his busy schedule. And beyond that, I also thank the moderators, today's moderators, Dr. Jairam sir, Dr. Tilagavati, who did an excellent work coordinating all the things in spite of the network issues, and also all the speakers, Dr. Abhirami, Dr. Ria Lawrence, Dr. Jairaman, Dr. Gayatri, and Dr. Sridhar. So the topic, everything was very big. We all had a very good bird's eye view of every topic. And overall, I thank all the delegates and participants who participated. Almost the thing was filled with 1,000 within 20 minutes. And the crowd was up to 900 plus, even up to 5:30 p.m. So, as our chairman told, I, on behalf of the AMS TNSP, welcome you all for the 3rd day tomorrow. The topic is on ophthalmology. It's a 5-day program totally. So, first 4 days it's online, and the last day it's a hybrid mode. So, we have completed the day 2. And thank you all for the wonderful evening, and we'll all meet tomorrow for the day 3. Thank you.
Thank you all. Thank you very much, IMA, AMS, and all my faculties. Tilaka ma'am, thank you very much for the wonderful time you spent here for more than 3.5 hours now. So from 2:45 to almost is 6:25. So thank you very much. Pranams to you, madam. Have a great day. God bless, madam. Thank you very much. See there, wonderful. Thank you all. So we'll meet tomorrow at 3 o'clock for an important session.
Thank you.
Thank you.
Thank you.